Второй канал, раз, два, три, четыре, пять, шесть, шесть. Второй канал, раз, два, три, четыре, пять. Отлично, да? Все.
It's happened in 2019 in China. In December 2019 in Wuhan cluster, seafood started at seafood market, and in January 2012 genome first analysis was made, and a little bit later it was confirmed that WHO recognized on 11 February as a disease. And after that it was named pandemic. And the first case in our country happened on March 11, 2020. So lethal rate or coefficient was 9.6%. For MERS it was very high, 34.4%, and the pandemic, which is still ongoing, it fluctuates from 2 to 2.5%. As far as, dear colleagues, as far as you know, it normally transfers through air with liquid, and incubation average time is 5 days. And the very important methods of protection and control, sources of infection, and what we can do to avoid children getting infected. For example, in our country, I can say we didn't go anywhere for 2 years. We didn't have Congress, so we couldn't meet. Everything was good, was under control, but as soon as children started going to schools, starting from September, situation aggravated, and there are lethal outcomes even for children. Protection equipment, in such cases we need to use medical masks, FFP2 and FFP3 and N95. What are the features? As a person gets older, it's about immune system. It's related to smoking, hypertonia, diabetes, cardiovascular diseases. And about the diagnostics and molecular tests of high importance, serology tests, laboratory helps us a lot, and rengenology. And we are afraid of cytokine storm, which happens from 24 to 48 hours, and as our previous colleagues said, acute kidney damage is pretty frequent with thrombic complications and septic shocks. Drugs which are used for support and treatment of a patient. And now, after brief introduction, I would like to tell you about my materials and methods were based on the background of our institute and hospital. It was a retrospective cross-section at the emergency department where we work. We had patients starting receiving from 11 March when it started in Turkey till August. 8,386 patients were registered, and out of them 1,868 patients older than 18 years old with preliminary diagnosis of COVID-19, and for 591 data was not available, and that's why finally we had 1,227 patients, and the result and the final diagnosis 23.4% got a COVID diagnosis, 24.5% didn't get COVID diagnosis, and others were diagnosed for other forms. Here you can see growth which started from March till August. That's the period when we were receiving patients.
So what you can see here is the world classification, and well, it is comparable to what we have in our country. And as was said earlier, 1,277 patients, 55 women, 655 women, 622 men, and then there's 287 were smoking, and then 151 quit, and the rest did not smoke. So what you can see here, the correlation between the sex, gender, and the COVID status. So here the gender distribution across the age groups. So as you can see, the patients were diagnosed with COVID-19, and the would be older than 65 years old. So here are the actually smoking patients, as well as those who quit or never smoked at all. So the symptoms were the weakness, dyspnea, coughing, and those who had dyspnea, fever, and coughing, they have received, they have been diagnosed with COVID-19. So the people who came to us without dyspnea, with dyspnea, they would be hospitalized into the intensive care unit. Now I'd like to draw your attention to the fact that the patients who were hospitalized at our hospital, so they had high blood pressure, diabetes, heart problems, and the very high percent, 11.6%, with the arterial fibrillation. And we believe that the patients who had COVID-19 diagnostic, who had such high fibrillation, that was due to the virus itself. Now, we see the patients older than 45 years old. They had the comorbidity such as the high blood pressure, heart problems, and arterial fibrillation. So what you see here, that the MRI of patients of with COVID-19 displayed dyspnea and the saturation lower than 90%. So here what you see the correlation between the GIT symptoms with the infiltration on CT of the breast. And you know, in the beginning of the 1920 we had patients who had dyspnea, low saturation, and after by the end of the summer, so the patients would rather have problems with GIT symptoms. So we thought that was the result of the fever, but then we realized that the real cause is COVID-19 indeed. So what is the arterial fibrillation? Where does it come from? Arterial fibrillation. So what exactly is? So it well, this is a sign of the heart problems, fibrillation. So the patients with the light forms, with these symptoms that are light, is it easier for them with the COVID? Well, actually, no. It's those patients prove to have to have more difficulties. Thank you for the most interesting. Now I'd like to give the floor to Vyacheslav Sergeyevich from the Science Institute of the Ambulance, St. Petersburg, Journalist Institute. Thank you. Next speaker is Valery Matveyevich, and that will be online. Good morning, dear colleagues. I have a very short intervention dedicated to lactic acidosis during the septic shock. We believe that we knew everything about the subject, which was not the case. So the classics algorithm that was suggested in 1964 of the lactic acidosis by Cohen and Wood, and they modified it in 1983. So type A is caused by the hypoxia, type B is caused by other chronic diseases, vitamin deficiency, and some other problems. So the picture seemed to be clear. So that was the classical scheme. The hypoxia doesn't allow Krebs cycle to function, and which also inhibits piruvat, and then of course, and then as a result we have the lactate. So and the ratio here is 1 to 10 in favor of lactate. So 1.218 millimoles per liter. This is the molecule that we need, and it's a norm. Everything was clear, but it turned out to be much more complex than this. And it's difficult to correlate lactic acidosis, the quick type A, with only hypoxia, because the septical shock is true. The lactic acidosis is there, and it's quite considerable, 10 millimoles, 12 millimoles, and they said that it's a prognostic criteria of the lethality, and we still say this, but now we modify this and saying the dynamic for the first day is, and that's a forecast. If the lactate was 12 when the patient was brought to the hospital, and if it came 8 as a result of actions, that's a good forecast. It was 8, and if in the morning it's still 8, that's a bad forecast. It means that despite all our efforts, we didn't manage lactoacidosis and didn't go to the cause term. So the figures are over 10. And the blood loss is also a shock. It's one of the ways of hypoxia. There are hundreds of articles, so we picked just some. So the abscess streak blooding, for example, lots of blood loss, whoever dealt with obstetrics, you know how much blood is lost there. Is there any lactate acidosis? Yes, and it's 3 times lower. And so, is that the shock? Is it hypoxia? And if we have them both, why is it different when we have a sepsis and we have the blood loss? So lactate could be 4, lactate could be 5, or when the trauma lactate is 8, and it considers 8 because over 8 patient cannot survive. And when it's septical, well, it's always high. So hypoxia is not only shock, it's lung damage as well. So when the lungs is damaged, and so everybody remembers the coronavirus pneumonia, very strong acidosis, and then we saw there would be lactate acidosis, but it did not happen. So for the most 3.4 lactate for the gravely ill COVID patients is okay, but 8 we've never seen. So lung damage and apnea. So lung transplantation, edema, all this actually results in hypoxia. So we don't have a correlation between the graveness of the hypoxia and lactate. That's why, that brings the questions. So when lactate could be high when we have critical situations. So because that what Woods was describing in his book. Well, there is yet another scenario, excessive pirouette generation, and then it means that the cell has the excess of glucose, and well, the excess of glucose is not a normal situation because all the other cells receive glucose through insulin, so even if we introduce glucose into the body, it will not get into the cell. So you will have more glucose in the cell only if you have the cells which have glycogen. So that will be our muscles, that's our liver, that generate glycogen. But in order to kickstart the glycogenolysis, you need to stimulate it, and how you do it? By adrenaline. It's well known situation. So now, hemorrhagic shock, vasospasm. Well, of course, there's adrenaline, which causes the circulation, and then the cells do not have O2, but have enough of the glucose, and there is no large or excess of lactate. So vasogen shock that we have here, when the blood supply is okay, but O2 is deficient, and it may happen in other parts of the body, but adrenaline that stimulates glycogenolysis and the glucose generation. As a result, we have a great number of pirouette, which has no other way to go during the hypoxia, and then the lactate is on the increase, and we have that critical lactate acidosis that we see during the septic shock. So this is the mechanism, excessive pirouette generation, because before it was anaerobic processes which require no O2. So that's how the bypass is required. So lactate is the molecule that we need, and it may turn back to glucose, to glycogen, and then in the case of the energy deficit, so you have 6 lactate in order to 6 ATA to make a glucose. So just not very economical, and it's impossible during the critical condition of the patient. Yeah, another very important thing that the acid will not be very lactic acid actually is something we really need, and so that's one Krebs turnaround, 12 ATF molecules, and also 3 when the pyruvate goes to the acetator, so 15 molecules ATF, but having just one lactic acid molecule, and that's how it works in the body. So lactate can transport energy inside the body from one cell to the other, and then our myocard, how it gets these through the lactate, so lactate into pyruvate, pyruvate into Krebs. So our heart now, 40% uses the lactate fuel, so to speak. So we cannot survive without lactate. So it is very important. We shouldn't fight lactate molecule. We just use to normalize its utilization if we have the lactate acidosis. And then if the acidosis is decompensated, you have to corrugate, because acidose disrupts the process. So, but you don't have to remove it extracorporally, for example. You have to utilize it. It's a useful molecule, and to do that you kickstart the Krebs cycle. There are 2 ways of doing it. So pyruvate dehydrogenase, and then the next other one, alpha beta glutarate. So there are 2 very important fermate systems that will kickstart the this cycle. Now, you know, you must have heard about this drug, citroflavin. So what you see on the red, that's what you need to make pyruvate work. So number 1 is thiamine. There's no any orphan diseases, rare disease. So if we go along this list, we'll see our all our patients. If someone has no patients, well, they have some other symptoms. Well, alcoholism, for example. If we just check all my patients in St. Petersburg against this list, you are sure to check one of this. One is points. So the thiamine deficit is most certainly there. So if you actually subscribe the drug and didn't replenish thiamine, then, well, it's like producing a watch without a very important cog. So how can you make sure that you increase the production of watches? You cannot, because you miss very important cogs. So, dear colleagues, by default, and since we're talking about the septic, it's a B, or the other, or type A, as it used to be. So, but in fact, it is type B. Let's stimulate it. Normal work, aerobic system. So that's what we need to do to kickstart this Krebs cycle. We need necessary instruments, and of course benazine and the riboxine is the drug we really like. So we used to apply it in 1990s, and we believe that rheumatologists who actually use more of the riboxine and actually inject it to the patient, he was the best, but which was not quite the case. So it may turn into the adenosine and activate the purinic system. Well, I really doubt that. As a result, we can have a problem with the heart. So, but if we give too much of the riboxine, and then we'll have a collapse. Even when we used to do it, we didn't have this eventuality. So there are well, different ways go around it. So nicotinamide is one of the ways to do it, because if you know the molecular structure of this solution, then you will need these drugs in order to receive the result. So now the patients who are admitted, they have the hydrocarbonate, some are not. So in the Western countries it's 720, 1570 pH, and after that you apply hydrocarbonate. The question is, do you have to wait? So what really surprised me is that we have a patient in the intensive care, so his critical acidosis is there, but the analysis result is 725 when the deadline in the study is 775. So I just go and drink coffee and wait until it goes up, and then I do something. Probably we shouldn't intervene earlier and stop him before he goes to the edge. Can we synthesize his own carbonate? So why is it 720, pH 720? Because beyond 720 is a catastrophe. Should it go any lower, then everything will crumble, because he is really at the edge. And do we really need to allow him to go to that edge? That is the question. 2 anions, natrium solutions resinter the carbonate in the cell itself, so you can see the way it works. We published it before, of course. And number 2, when we recently did the jade acid, so it becomes a hypoxanth. So this succinic acid will lead to the oxygen replenishment, because without this process it will not be possible. So by replenishing O2, we are kick-starting the Krebs cycle, and then lactate started to work as the energy carrier, so it helps the body. So it's a 2-valent solution, so we divide it by 2. So for 1 mole, it's there are twice as much. So this is what we've done in our institute.
And the consumption of oxygen is growing, and we get back to Krebs cycle. We enter Krebs cycle after CO2 generated. We give 4 carbons and there are no carbons. And here using CO2 is not comfortable, and we can corrugate hydrocarbonate, increasing it up to 20. Thank you. And the floor is given to Valery Matveyevich. He is from Scientific Research Emergency Institute. Jamalidze from St. Petersburg. 10 minutes. Features of nutrition support in cases of sepsis. Yeah, there is a record. Please. And first of all, it's about energy and protein support. I would like to make you familiar with the protocol for treatment. Okay, prepositions where all know the sepsis related to category pathologic states accompanied by express system metabolic dysfunction. We know that early nutrition metabolic therapy with changing peculiarities related to prioritized method of its basic therapy. And I do believe that absence of such a type of medical guidance in the course of intense and main goals in process of nutrition metabolic therapy when for sepsis, it's providing physiological demands of patient. It's correction of excessive activities of system inflammatory response of a body to infection and metabolic disorders, early block catabolic block a transition of a body to anabolic phase, and of course it's increase of compensatory abilities of organism. And clinical nutrition is normally considered as dietology and aimed to treat. So the definition is used methodological therapy, and these are the issues of optimal energy and protein provision. What are the preferences, energy or protein, and times of providing nutrition? Traditional questions: how much? What is the quantity? There are three approaches for a choice of a scope of substrate. There is empirical approach, calculation, and indirect calorie metric approach. And we need to understand that this is a dynamically changing indicator which directly depends on a clinical situation. If we are talking about empirical approach, as far as I know, that's in line with the system of recommendations by many guidelines nowadays. We have two categories: stable and unstable patients. Unstable patients, there is a recommended energy and protein support. In process, its energy 20 to 25 calories, 1.2 grams of protein a day. And if we're talking about azotemia without dialysis, and for 1 gram of nitrogen with the maximum use of protein, classical use, we need to provide not more than 90-100 kilocalories, and we need to keep in mind limiting factors, but catabolic nitrogen and hyperkalemia, and in stable states of patients it's increased in comparison with the figures, and ventilation dependency and protein support increases up to 1.52 grams a day, 20-25 kilocalories, and 1 gram of nitrogen, and less quantity. And if we're talking about empirical range, it's about 1,700 kilocalories a day, and there are calculation approaches. They are very well known, and the simplest formula is defining energy consumption, paying attention for the state of the patient, stable, unstable, depending on hypercatabolism, and 4 minutes 25.5 kilocalories, for women 20 kilocalories. Energy consumption is decreased every 10 years, and we're talking about aged people, so average quantity should be decreased by 20% energy consumption, and structure of oxidized, paying attention for breath coefficient, and it demands multiple 30 minutes checkup on a daily basis, which limits possibilities of utilizing this approach. And that's why protein energy support, when we determine loss of urine coefficient in daily urine sample, we multiplied by drainage losses. It's about 15-16 grams of protein for each liter, and we had 2 grams. And when we had these nitrogen figures, we transfer it to protein, and we can personify protein support for a specific patient. And nitrogen losses, comparing with the data by indirect calorimetry, and depending on nitrogen losses, enable us to personalize energy support. And we kept in mind that this figure should be within the range from 80 to 90%. And here we may see figures. I'm not going to stop on this because this presentation will be given to you, and after that you can study. And the main losses of patients with sepsis, around 15 to 20 grams a day approximately. Here we have data energy consumption with different sources of sepsis. Average figure of energy consumption was 31 kilocalorie per kilogram a day. There are different sepsis: abdominal, pulmonary, and neurosepsis. And if we are talking about the range from 80 to 100%, the scope of energy support will be 25-30 calories per kg. And we should pay attention that in the course of more detailed analysis of sepsis outcome, depending on power consumption, with more than 30 kilocalories, lethal rate was 23%. It was 1.8 times less. And this nitrogen less, which were determined for more than 100 patients, and the most losses were 1.52 kg a day, and the main goal is to minimize tempo of developing sarcopenia, because we understand that insufficient protein can be accompanied by autophagia, and muscle tissue is involved in the process as well. So the same for protein consumption. of more than 1.5. Lethal rate was 2 times less for this category of patients, and lethal rate for patients with less than 1.2 protein. That's why we recommend for sepsis patients to have at least or more than 1.2 kg a day. Recommended range is from 1.2 to 1.5 up to 1.5 kg a day. And this is our protocol, and it shows gradual increase of protein load in order to reach planet indicators. Here is the first day. There is electrolyte solution, and after that, if everything goes right, we increase on third day 1000 isocalorie solution, and after that we get to hypercalorie and 1500 kilocalories for an average weight 70 kg. It's about 1 gram per kg and 21 kilocalorie. And here, starting from the day 5, we personalize support. There could be mix and solution with Isaac. In case if we don't succeed to get the minimal scope of planet support, in this case additional nutrition accompanies support. And what is obvious for today's sepsis, it's a systematic inflammatory reaction with prevailing hypercatabolism, so structure of substrate oxidizing changes for lipid and protein support should be not less than 1.2 1.5 kg a day. So energy support for a patient with sepsis in the scope of 25-30 kilocalories kg, and support should be carried out gradually with accompanied by nutrition solutions, and paying attention for metabolic response. And that's why there should be the line of different nutrition solutions. And energy wise, 25-30 kilocalories kg, and recommended 1.5, which enables to decrease lethal rate of sepsis patients. Thank you so much for your attention. Here you can see internet site where you can know more information about solutions and look through protocols we use in our therapy, and thank you so much.
Well, I would like to thank you, because what can I say about the nutrition support in Uzbekistan? So 10-15 years we paid less attention compared to the last 5 years. Now some companies supply for parental nutrition to Uzbekistan, and now we pay more attention to enteral nutrition, because before, so all this eggs, cottage cheese, we were not sure if it's really absorbed by the body or not, but that was the way the patients were fed. And the body needs material. It needs the building blocks. Without it, well, the intensive therapy will be futile. Therefore, not only during sepsis, but also when we have critical condition, we have the disruption of the water electrolyte balance. So parenteral feeding, that was the most, we didn't pay enough attention. So pancreatitis, for example, acute pancreatitis, again this issue is very important, what to feed the patient. So, and then of course all the toxins from the GIT are indeed evacuated. So parenteral enteral feeding is better than the other one, and therefore it's very important to introduce enteral feeding. Now give to floor to Husan Salavatov. Criteria of differential CT scan and in the conditions of pandemics. So that will be interesting for our guests. There would be to know that we have the specialized COVID centers in Tashkent, so 80 in Zangieta number 1 intensive care beds. So we have our anesthesiologists working well. Floor is yours. Good afternoon, good morning, dear colleagues. I'm the X-ray radiology physician at the clinic number 1. Tashkent would like to thank the organizers for this opportunity to make my presentation. Criteria of differential CT scan diagnostics and the changes of the lung tissue at the COVID. So of course symptoms, each diseases have its symptoms and clinical patterns. So in CT scan, one will be the matte glass, which will show the vessels and then and the interbronchial space and the walls. So we can find this phenomena in any other pneumonias. So if you look on the right, you will see the matte glass during the alveolar edema of lungs, and in the lower picture is a patient with a COVID infection. So on this slide you can see step by step CT change the dynamics. So with the alpha strain of coronavirus SARS-CoV-2, so you see the dynamics, well, the matte glass manifestation in 3-5 days. We can see consolidation where not only the intercellular fluid but also in the alveolar the substrate is filling them. So we can see this changes. So that will be on the 3rd, 5th day of disease. On the 9th, 10th day, when the therapy, normal therapy is applied, substrate is gone, we have some remaining reminder changes. reticular changes. So you can see this boulder streak kind of picture and the certain net. So, and then we'll see the resolution on the 9-10 day. We have the fibrosis changes, and then all the actually disappearance in the parenchyma of the lungs. So when patients were brought to the clinics in time, so we would see the patients from actually stage 1 going to stage 4, the last one, so the patients would be effectively cured. So all the bodies have well, ability to change, so our coronavirus is ever changing as well, and therefore so we have certain mutations that have been registered, and it's apparent that so there were some changes in the structure, and there were very in charge of the virus, and it could be seen on the CT scan. So at the peak of the pandemics in the Zangata number 1, by the end of the June, we saw the first new atypical variant of the COVID, and so we see a different picture on the CT scan. If in typical COVID-19 we would see the mad glass, so here we saw a different situation when we had the areoles or the ridge symptom, and with the perfocal mad factor in the center. So you will recall the picture of the sea mines, water mines, and the reason I use that image is that that's what it looks like. So, and then of course on the first slide you will see the early stages of alpha virus. So again, matte glass, more outbursts. On the second picture you see areole symptoms, multiple outbursts with the perfocal matte glass. So this is the first stage of the coronavirus, and the further changes, consolidation stage in alpha state in 3 days time. So there are changes, and the patient, we will see that some outbursts disappeared and some outbursts actually were consolidated. So we see the same patient in 8 days time, and so the smaller what we also see the healths of the hotbeds actually to explode, and the consistency change. So, and the same changes with the patients. On picture number 1 shows the 12th day of the patient with the alpha variant, alpha strain. So it's only the fibrosis which can also disappear after the rehabilitation. But with the delta in 15 days, what we see is the explosion of the health. So, and just like sea mines, so we see it is also 70% of patients would have the secondary fungi infection like Mycoplasma aspergilloma. and on the 21st day, the same patient, we see pneumofibrosis, so very high density areas, and so saturation will be lower than 86 even after the corona was gone. So in Zangiota number 1 during the pandemic, so it will be June, July, so we 256 tests were sent for sequencing, and 1,200 patients, so 81% actually revealed a Delta strain, Delta variant of COVID, and 99 of them, so 18%, it's a usual or general corona. So in July, we would have the prevalence of the Indian strain or Delta corona. So 619 patients were women, which accounts for 60%, and over 400, well, 38% are men. So we see that the women are more prone to get infected with this strain. And regarding the age brackets, so the patients younger than 25, 131, 12%. And the main Delta COVID infected will be the middle-aged people, 652 people, which is actually 63%. So will be the, well, this is the employment age patients. So above 50, there will be 254 people. We saw the minus 11 plus 45. So in conclusion, we have to say that the experience we have accumulated of patients for the Delta strain coronavirus allowed us to design our own algorithm of differential diagnostic strategies. Thank you very much indeed. Any questions to the speaker? If not, thank you very much for the most interesting presentation. Now I'd like to give the floor to Ilan Fokin, Deputy Head of the Anesthesiology of the Republican Emergency Center. He will talk about the blockade during the anesthesia of patients with multiple damage of ribs. Dear colleagues, it gives me pleasure to present to you this presentation. So what you see here is that we have over 200 cases with the closed breast injury with the ribs broken, so it could be either isolated or with combined traumas. People with the multi-traumas of ribs is the majority of them, so from with 3 or more ribs broken. So of course the pains when you have the multiple damage injury of ribs is very intensive. So, and then the simple physiological actions like breathing, coughing, or changing your position actually increases the pain, and different complications may appear. So to avoid these two extremities, like the drugs, analgesics, and based on the multimodal analgesia, and actually uniting the system analgesics of different kinds, and using the ultrasound assisted regional analgesies. So on this slide you can see different kinds of analgesia when the ribs were broken in 2 stages, before and after the ultrasound, and then when such methodologies such as epidural energy and the paravertebral blockade has its own minuses, which does not allow to use them routinely to actually apply anesthetics to patients with such injury. And once we apply ultrasound, and we're using the facial blockade, when we blockade the certain spine unfolding muscles. So the local anesthetics is administered to at this part of the vertebrae, as you can see, and close to the muscle that we mentioned earlier. So and then going through this paravertebral area, and it blocks the spinal nerves. So we see here is the articles that were written on this topic, and the facial blockade or erector spine block. It was known in foreign literature, was first described in 2016 by Ferrero and a number of authors who used it with people with breast neuropathy. Then there were also articles that described the mechanism of influence of this anesthetics when the local blockade is used, and the articles with the research on clinical efficiency of this methodology in different areas, and one of them was indeed the use of this blockade with the patients with the injury.
And the aim of our surveys was determined efficiency of anesthesia for multiple for patients with multiple rib breaks. Blockade techniques can be in sitting posture or laying posture. In order to have blockade efficient, it's desirable to use it assisted with ultrasound when cross-section and after contact with cross-section, local anesthetic is applied. The elastomeric pump could be connected as well. And the main points for our survey was a digital evaluation and comparing 2 groups of scale. First, viable volume of lungs, and use of drug analgesic. Statistical analysis was carried out with the use of StatTech software, and distribution of patients in 2 groups. And the quantitative distribution of 2 groups was slightly different, and groups were homogeneous. I'm sorry, I missed one slide. And in our perspective, survey included 41 patients with rib breaks, and for anesthesia, facial blockade was applied, and system analgesics were prescribed. System analgesics for anesthesia were prescribed. So results. So digital rating scale of pain. rest. It was slightly different and at average, and was 2 times less in comparison with the control group. And consumption of drug analgesics for the main group was statistically significant and differed 2.3 times in comparison with the control group during second and third day accordingly. And fourth, lively volume differed, and 3 scale components. And we might say that this is a dynamic scale for observing patients with ribs broken. And average arterial pressure for both groups didn't differ without considerable fluctuations. And partial pressure or arterial oxygen was higher in comparison with the previous results. Also, I'd like to present you the results of our survey on local anesthetic when we reported during 17th Congress of Anesthesiologists of 6 persons with multiple ribs break. We made counter-survey of local anesthetic, and it was revealed by us that only 1 patient with local anesthetic and clinical effect was for all 6 patients, and that's why it's a subject for discussion, how anesthetic impacts directly or indirectly. And we can make conclusions that fascial blockade is the efficient method when anesthesia for patients with multiple rib breaks. Thank you so much. No any questions, so thank you so much. And next speech, balanced approach for metabolic acidosis correction. Orlova Olga Viktorovna, Scientific Research of Emergency Institute, named after Genelidze, St. Petersburg, Russia. Good afternoon, dear colleagues, and many thanks for this opportunity to visit your beautiful country. And this is a very kind of considerable event about correction of metabolic acidosis for patients in emergency departments. This is a very relevant subject because any critical state is accompanied by disorders of acid equilibrium, and depending on how fast we correct the fast we can compensate adaptive possibilities of a body in order to speed recovery time up and to decrease lethal rate. And I would like to say a few words about metabolic acidosis. We know that from the position of Peter Stewart theory, there are 2 groups of acidosis. It's acidosis with high, with normal break, and acidosis with high break. And when there is a high anion break, of course we need to make diagnosis, and the most frequent metabolic acidosis, it's lactate acidosis. And Vyacheslav Sergeyevich is already mentioned this subject. We need to understand which type of lactate acidosis is for our patient. Of course, in the conditions of emergency medicine and critical states, we normally think that it's a B option, fast lactate acidosis, but we should keep in our mind that patients normally have some comorbidities, so it can be accompanied by other lactate acidosis. For example, those patients who received gut surgery, and in the critical state they can have burns or other traumas, so in this case it will be comorbidity. So what's very important for diagnostics, of course we should calculate anion break. This is a very simple formula. What is very important for this calculation, we need to keep in mind the level of bulimia. Sometimes our patients have a low protein level, and that's why it is necessary to correct hypoalbuminemia. And for our understanding, we need to understand the level of lactate of blood and bicarbonate. What are the clinical indications of acidosis? Main effects of metabolic acidosis. And we need to remember, if we observe clinical absence of adequate response for vasopressors injection, we need to think that first of all we need to correct, because blockade of alpha receptors is developed on this background. What we have for correction of metabolic acidosis? There is a pretty big wide range of drugs. One of the most known, and first we start thinking of this is hydrocarbonate of natrium. How do we calculate necessary quantity is here on this slide, but we need to remember. But the most formulas are for solution concentration, so-called molar solution, and our Russian pharmaceutical industry produces different types, 4.2 and 5% of hydrocarbonate. And when you make your calculations for quantity of hydrocarbonate, please pay attention for which solution you have in use. And the second feature I would like to mention, that if there are marginal deviations, in this case hydrocarbonate of natrium, and we can infuse our with correction and evaluation of acid equilibrium in order to compensate losses and corrigate acidosis. And the data presented for correction for bicarbonate therapy, which Vyacheslav Sergeyevich already mentioned about that, tells us that we need to wait for pH in order to infuse hydrocarbonate. But once again, why should we wait for critical indications if we can correct it early? What is important when infusing hydrocarbonate of natrium? There is also so-called ricochet effect, and in 12 hours resynthesis of hydrocarbonate is possible. That's why it is necessary to make a control after 12 hours because after that patient may encounter alkalosis. And next drug I would like to mention, it's a hydromethylaminomethan or trisamine. Unfortunately, now it is absent in our country, but this drug is good because it corrugates in intracellular acidos. In order to infuse it, there should be a regular kidney function, because it cannot be efficient until the function of kidneys is restored. And from our point of view, for prevention of progress of acid equilibrium disorder, it's succinate natrium drug. It was already mentioned since 2 molecules or 2 mole, and it appears that meglumine natrium molecule, 2 hydrocarbonate molecules are formed. You may see it on the diagram on the scheme. And this drug has balanced content, polyionic content for natrium, for kalium and magnesium, and we can use it for infusion therapy for our patients. And even at the initial stage, when acid equilibrium is in subcompensated state, it has effect which helps prevent further disorders. In addition to that, we should remember we already discussed acute kidney damage, and by method of choice of correction of acid equilibrium disorder, there is a replacement kidney therapy. We have it in our recommendations. There are KDIGO European recommendations as well, and this method of therapy, it brings back level of bicarbonate to normal and pH level, and blocks hyperkalemia and removes toxic elements. So in conclusion, of course, personalized approach is required, revealing reasons for acidos and choosing optimal correction method. Of course, we shouldn't wait pH 7.2, and we should start correction much more earlier. And we need to remember that there are comorbidities of patients which we should pay attention for, and to make correct correction. Thank you so much for your attention. Thank you so much, Olga Viktorovna. Ladies and gentlemen, any questions? No any questions. Thank you so much. And the next speech is online. Anesthesia features of aged people. Loskutov Oleg Anatolievich, National University, named after Shupik, Kiev, Ukraine. For the start, I would like to say thanks for organizers and for invitation to take part in such a significant forum, and to tell you about treatment of aged people. So I would like to tell you there will be a conflict of interests in my report and statistical data in Ukraine nowadays. 65 and older is 16.8% of population, in line with WHO data and international criteria. Aged people, if the share is more than 7%, and this trend is typical for many countries of the world, because the world is getting aged, and we work with aged people more and more often. And what is about post-surgery treatment of such patients? This group normally has a few comorbidities, and in line with our international colleagues' data, about 65% have pathologies and comorbidities, and 62% of patients 3 and more comorbidities, and 43% of bed spaces for the group from 65 to 74 and 65 surgeries are carried out for patients older than 64, and one of the most dangerous complications during surgery, it's post-surgery delirium development. And as it is mentioned in international scientific works, post-surgical complications such as delirium will appear more and more often during upcoming 6 decades, and patients with delirium are at intense care departments are considerably longer in comparison with the patients without such a type of complications. Moreover,
we also have the delay to lethality, which is 7 times fold of that as a patient who didn't have the post-surgery delirium. So all this is, of course, the reason why the National Committee of the U.S. Surgery College and the U.S. Geriatric Society issued a recommendation, and I believe it is quite an interesting one, which says that for the patients with the risk of post-surgery delirium, so we're talking about patients advanced in age, using the benzodiazepine should be avoided unless it is absolutely necessary. So using, or rather not using the benzodiazepines is a prophylaxis for the development of the post-surgery delirium. So what are other factors can lead to this complication during the post-surgery period? So as you can see from this review, these factors could be the level of the hematocrits, comorbid pathologies, functional status, the low intraoperation hypertension, and also albumin levels. So many believe that the albumin lower than 2 to 3 grams per liter is independent statistic predictor of post-surgery delirium with old patients. So yet another article that looked at over 700 patients between older than 74 years old, and with a level of albumin which was the prognostic level, which actually pointed to the post-surgery delirium. And the outcome or conclusion is that our results point to the fact that our patients after the non-adult surgery, the pre-surgery hypoalbuminemia is indeed less than 30%, and which is not be ignored. And a few words about the hypertension. So there was an article in the specialized journal which showed that the fluctuations of the blood pressure beyond the diapason of the range of 75 to 135 and 85 to 145 millimeters before and after the surgery, which was connected with a 30-day lethality of these patients. Moreover, the decrease of the arterial blood pressure during the surgery, even for 5 minutes, would increase the risk of renal dysfunction by 1 0.3 times, and the decrease of the arterial blood pressure beyond this range for over 10 minutes is actually would result in the cardio complications by 1.5. So another aspect that is very important, in my opinion, for the old patients is the adequate cerebral blood flow. And as our research indicated, the decrease of the arterial blood pressure by 32% on average at the level of the internal anesthetics may actually lead to the decrease of the blood flow by 46% on average, and the increase of the arterial over 19%, and would actually lead to even further decrease of the brain blood flow. Stromal is the name of this phenomenon, and as the certain researchers showed, that the decrease of the albumin less than 31 gram per liter is the independent predictor for the complications with the renal dysfunctions by 2.7%. Mediastinitis will increase by 4.3%, and prolonged ventilators of lungs with the frequency with the AVL time as twice as much. If the previous authors would define the threshold albumin as 35, then the next research and study, which included over 1,300 patients, showed that the albumin less than 40 grams per liter is an independent predictor for the acute renal damage during the cardio surgery. And yet another research that is actually looked at over 4,000 patients established that the lethality increased by 147% with every increase of the albumin by 10 grams per liter. So why is this albumin level is so important in forecasting the development of various complications? This is one of the works that demonstrated the renoprotectal activity of albumin, and I will just cite from this study that the albumin may have the renoprotectal impact on the cell and molecular level, and albumin enhance the diffusion of renal filtration and with prolonged expansion of the renal vessels. So albumin is not a biological active molecule which helps to sustain the pressure, but the latest research show that albumin may also impact the function of the cells that it contacts with at the signal molecule. So albumin can modulate the penetrability of vessels by changing the intercellular cancel, and albumin, which is suggested by the various commercial companies that we use. Well, they have the international certificates, and no company, know-how of the Takeda company when they produce albumin is in nanofiltration, when you remove the pathogens by excluding them by the size factor. So block viruses actually go through the filtration using the antibodies, and those bodies are bolder than the antivirus 35 micron filters, and that's how you ensure purity of albumin. 3-component solvent detergent processing also lead to the destruction of the membranes, and also it may actually inactivate the viruses with the liquid covers. So now with this I would like to conclude my presentation, and thank you for your attention. Thank you. And now I would like to give the floor to Alla Leontievna Rostova, the concept patients with the combined traumas with the complication with the acute respiratory dysfunction. Thank you very much for all those who organize this seminar, and of course we already talked about the urgency of the combined traumas and the breast injuries, and the lethality is very high within this group, and in combination with the combined trauma and trauma of the breast could also lead to very high level of lethality. So we talk about the adolescents, and so those people who are in the employment age. So we should understand that the treatment tactics of these patients is very important. And so what we need to do at the earlier stages to identify these patients, and then of course one of the specificity of these patients is the respiratory syndrome, hypoxemia, and of course the main respiratory support is to support gas exchange in lungs, and support the breathing function of the patient, and opening the alveolus, and then support stability of alveoles and the open condition. So of course the same problem, that the lack of the recommendations for this kind of patients and its negative impact. So currently, according to the protocol of the billing, we have the diagnostics of the ORDC, and so our aim was to look at the rationality and efficiency of using this method with the patients with the combined breast injury. So what have we done? We did the treasuring on transpulmonar pressure. So as you can see here, we would introduce into the trachea the meter to gauge the pressure, as well as the feeding sound in the lower third of the GIT, and then we look at the cardio oscillations on the curve, and as this is how it looks like. So this is the meter, and that's how we gauge and measure the pressure. So what is the pressure? And so transpulmonar pressure is negative when the person is overweight. For example, when we have the abdominal combat syndrome, when a patient has edema, when there's abdominal surgery in the way. So when we have the pressure from the diaphragm, and also pressure from the breast wall, and of course when we have the lung distress, so it requires very adequate and expedient decisions, and we should really understand that, otherwise we'll have fibrosis, and the patients may actually transfer to a non-occupated condition. And so when pulmonary pressure is positive, 1, 2, it's reckoned to be positives. For example, when we have the CPAP therapy, when we have the PEEP on the ventilation. So here we can open the breathing tract irrespective of the pressure. And of course the positive pressure is positive, but we need to know what it should be, 5, 10, 15. There are certain boundaries that may have negative impact on the parenchyma of the lungs. And of course the transpulmonal, positive transpulmonal pressure is not good because it leads to the overstretch, and it could be volume or a barotrauma. So we have the expansion and the expanded alveolar presses on the capillary wall, and the oxygenic efficient will be lost, because we shouldn't forget about the driving pressure, driver pressure, that is a difference between transpilloral pressure during the breathing in and breathing out. So therefore we need to also concentrate our attention on that. So it's over 15, it's over expansion, so some literature says it should be less than 12 as the optimal for to have a good hypoxemia of these patients. And so we have to look for the optimal PEEP for each patient. So of course we are in different conditions with different blood pressures, so therefore we should look at the breathing parameters, the height of the patient. So these are all factors to be factored in. So sometimes we should raise it, some decrease it. So this is a gadget that we have, what helps us in our work. So Mr. Sergienko already presented this device, because he's one of the creators of this gadget. So we look at the pressure, delta V, and then transpulmonary pressure that we need. So, and as you can see on the slide, what you can do, we can see when we need to increase, when we need to decrease the pressure. So we have 3 zones basically: red, yellow and green. So green is where we want to be, so that we open the alveolus. So as you can see here, minus 27 when the alveolus are shut down. So what we're trying to do, we increase the PEEP, and as a result we see that the increase of pressure in the breathing duct, and the alveolus open up due to the PEEP application. So, and of course there are certain criteria to include in our group. So those will be the patients with a combined trauma of head and breast. So, and also the acute respiratory syndrome, distress syndrome, and then also the low oxygenation index. So we looked at 27 patients, and all of them were in the neurosurgery and surgery department of the Republican Center of Emergency Medicine. So they are, according to the Apache scale, between 731, so with the cane, injury and trauma, and then with broken ribs between 4 and 2, without lung complications. Really the monitoring of the cranial pressure, the gas in the blood, and of course where we saw that the patients differed depending on how the depending on the PEEP. So in one group it was a PEEP between 5 and 8, and in another group it might actually go to from 8 to 25. So, and then of course we took into account the intracranial pressure, and these patients, of course, so they had a very high PEEP during the 30 minutes. As soon as we saw the parameters change, the gas saturations in blood, first of all, we would bit by bit actually bring it down, and of course factoring in the intracranial pressure. And we saw the growth when we saw whether people would go over 15. And it was all dependent on anatomical peculiarity of the patients. And we would measure the pressure up to 3 times a day. So once was enough to for the selection, and of course for monitoring, and we would control for this measure. So because we dealt with the patients with excessive weight over 3 times a day, so patients in the first group, we would increase 2 patients PEEP to up to 12, and as we know from different literature, so the range of opening of the alveoles, it goes between 13 to 22 of the PEEP when we do the selection, and the opening window is very difficult to catch, especially when we do the step-by-step methodology of raising PEEP. So we do it blindly, and not very often we can actually get the right PEEP. But when we do the transpulmonary pressure as a factor to choose a PEEP, then we can actually work with such patients, and then these patients with the respiratory distress syndrome, and in the first hours after the admission, the gas in blood will go down up to 47, and then once we did the correction in the second group, in 2 hours time, the level would also peak up, and in 12 hours it would go to normal. That means that we did the correction rightly. So nobody would go as to 29 with the PEEP, especially with a patient with excessive weight, let's say 200 kilograms, and when you see at the X-ray that there's no adequate ventilation, and after 12 and more, you can see the opening of alveoli, and once again we need to control the internal pressure.
And we developed monitoring an algorithm of taking care for these patients for the KV level, and nowadays we keep working in this direction. And to finalize, I would like to stress that early evaluation of transpulmonary pressure enables proper treatment for patients with lung respiratory distress syndrome, and paying attention for considering cerebral hemodynamics, which is related not only gas content in blood of patients, which resulted in shortening treatment time. Thank you so much for your attention. Thank you. Please, do you have any questions? Thank you so much. It's a very relevant issue. Upon receiving our patients have this treatment, our patients mostly were related to accidents, cranial trauma, did you make a bronchoscopy? Yes, of course, because the obturation, and if bronch is obturated, our patients were without desperation. We we didn't take the internally, so we didn't include them into groups. So include thank you so much. We have 3 more speeches. We are running out of time, and 3 speakers online. We cannot reduce it, and that's why next speaker, we will ask them to slightly speed up. Oleg Alexeyevich from Reanimatology Center from Moscow, cerebral hypothermia with chronic conscious disorder. Thank you for an opportunity to speak out during your forum. I recorded my speech. Good after the result for patients with chronic consciousness disorder. Good afternoon, dear colleagues. I represent my report on cerebral hypothermia with chronic consciousness disorder, and I would like to mention thermal balance. And this powerful metabolism is provided by almost 20-25 of blood circulation per minute, consumption about 25% of oxygen and glucose, and more warmth is accumulated in brain, and in this case, if you can hear me, I would like to demonstrate this slide which shows how temperature distribution on the surface of brain of healthy patients, so we can see equal distribution of temperature, but patients with a stroke, a zone of hypothermia with the brain temperature from 29 to 41 degrees. Since the brain is thermally productive, it's about 20% of all the temperature which is generated by the brain, and warmth is collected. Oleg Alexeyevich, could you please show the demonstration? We cannot see your slides. Temperature is integral feature of metabolic and functional activity of brain. I'm sorry, there is a mismatch of record. Okay, and I'll come to the results. Upon reaching temperature up to 57 degrees Celsius, it enables a decrease of temperature not less than 1.52 degrees, and evaluation was done in line with this scale. And radiothermometry, it's checking taking temperature of brain was done with help of MTM R1 RS. Here on the slide and on the picture you can see how we measure temperature and how temperature is changed during 120 minutes of therapy, and patients in vegetative state and minimal consciousness state temperature is equally distributed. And after that, unfortunately we couldn't demonstrate his slides. We switch to the next speaker, Kabeletsky Yuri Yurich. Ways to improve efficiency of pressure for people with cranial trauma. Dear colleagues, I'm grateful for data for new opportunities of internal cranial pressure for patients with severe cranial traumas. It's a problem in our region, and we have specialized department and principles for cranial trauma treatment. This undesirable process of hypertension is a definite fact. And the second dairy damage is hypoxia, hypoxemia, arterial hypotonia, intracranial hypertension, and this is the task of an anesthesiologist, emergency specialist to deal with it. We pay specific attention for surgical methods, especially to bifrontalectomy, which provided improved results of treating our patients' lethal rate during the first period when severe trauma was 52.9, and nowadays we have 36% decrease, and the functional outcome is considerably better if we are talking about normal recovery. Without hesitation, about patients perished, most of them had low rate blood circulation, and here we have different protocols of intracranial pressure in order to have it not more than 20% deviation from the standard. It's decompression, sedation, and so on. And now we pay main attention to monitoring of intracranial pressure, because clinical features are insufficient to evaluate. And it was the first time when we used an Ukraine invasive measure of brain temperature, cranial temperature was utilized, and it provided better understanding of what are the processes intracranial processes. And spiral CT was also used. And among new opportunities which we widely utilize, and the drug invasive wall, it's a very important the anti-inflammatory feature, and that's why this is multifactorial treatment was included into our therapy. And a few of our surveys It was a clinical experimental survey, and here we see the model of experimental endotele and intertele. So all the application points were released in the scenario, and here we can see a micromorphological picture, and it was demonstrated vascular damage is absent in peripheral zone and in the distant areas. In the distant areas, this percent was even higher. It is very important that comparative quantity of neurocytes on the background of using osteonide in complex therapy was proved to be lower. That's why lethal rate by 28 days was decreased down to 7.5%. So it was 70-80%, and now you can see this considerable difference. We pay close attention to have osteonide use already in emergency vehicle because it's drastically important, and our colleagues, surgeons, decrease of average mark in line with the scale was 49.7%, and that's why efficiency was considerably improved. It's very important the dynamics of intracranial pressure. A few days after oxygenate was started to be used. It's very important that by 7th day we didn't have episodes of blood pressure, and in the group it was not used. We could observe growth, increase of intracranial pressure. I would like to pay attention on the results of clinical surveys, efficiency and safety of lisinopril during treatment of brain and post-surgical nature. These are 4 institutions in Ukraine. It was average grade, and 2 out of 3 invasive therapy was used. So what we got, survival rate was increased, so chances to survive were increased for standard therapy 24.2 perist, and for invasive osteonide 10.3. Hospitalization duration was increased. Consciousness recovery was for 80% for the main group and 66% for the group which osteonide wasn't used to. So you can see that the survival rate for of those patients who took this drug. So overall state of patients considerably improved, and it's very important interpretation of the results. In cases when lisinopril was not prescribed, and on the background of using this drug, up to 25%, and 30 days lethal rate 28 and 29, and probability to survive was increased on the background of this treatment strategy. In addition to that, I would like to say a few words about importance of site protective strategies today, as it is aimed not only at neurons and vessels, but for those points of application where we use cytoprotective technologies, especially glutamate natrium, which becomes toxic during cranial trauma, and Alzheimer also related to chemical activity and involves glutamate. In case it is acetylcholine also increases density of receptors. Anti-glutamate actions are of high importance. That's why in the course of the last survey it was demonstrated the early prescription can be used for improving results of cranial severe disease. And it's very important that results consider for the correlation and positive outcome. And one of my first last publications in 2021, Citicolinaraxone is able to improve and to shorten consciousness recovery time. Let me skip conclusions, and once again I appreciate and thanks for your opportunity to speak out in front of the next Loskotov Oleg Anatolievich, methods for patients with heart diseases. Dear colleagues, I would like to share our experience with you of minimal opiate anesthesia for heart disease patients. What motivated us? Only interest? No. And the thing is that nowadays prescription of drug analgesic at clinics has become epidemic. And I would like to provide you with the following facts which were published in emergency department, increased from 150 up to 200 persons, and in Oregon state during just 2003 more than 2,000 people received prescription for opiates, which is 24% of entire state population. And there was, and this is the burning issue. And what could be the solution? You can ask. Prescribing analgesics in the clinics, and what is the reason for such an increased demand? And the answer, and the survey is the answer for these questions. And Medical Disease Control Center identified direct link between prescribing analgesics for patients and probability of dependency or addiction from these drugs. And you may see that during all 10 days of a regular prescription for drug analgesics, moreover, from the time of Septanil in 1999, there were works where was said that intraoperational patients who received low doses required much more morphine during a post-surgery period. So it inducted and prescribed.
So prescribing those in the early stages of surgery it seems to be unavoidable, but they may actually inflict harm. So one of the articles in a specialized journal actually provides analysis of over 341 deaths from the ischemic damage of brain as a result of the opioid analgesia in the immediate post-surgery period, and 40% of them have the established diagnosis of post-surgery apnoea. So, and of course, it was the unprecedented monitoring that you can find in any clinic. Despite that, and therefore, we decided to tackle this issue, multimodal small opioid analgesia, and then with this in mind, so we have singled out 39 patients that were subject to autocoronary bypass grafting in the conditions of the artificial blood circulation. So, and the age bracket was between 63 and 76, and the average time was between 219 minutes, and then of the anesthesia 250 minutes. So this was our algorithm when we applied our small opioid analgesia. So ketoprofen, that's what we start with before the induction, and then propofol 1.2 milligrams per kilogram, fentanyl 1 milligram, lidocaine 1 milligram per kilogram, and then relaxants, and intubation of the trachea. And to sustain the anesthesia, we use the sevoflurane with the BIS monitoring, lidocaine as a infusion on the dosata, so between 1.5 to 2.5 milligrams per hour, and dexmedetomidine 0.7 per kilogram per hour. And before the section, the patients would be administered 0.5 milligram per kilogram of ketamine, and infusion of lidocaine would continue afterwards. So what we received as a result, the average dose of fentanyl that was used during the anesthesiological support accounted for 1.9 kilograms microkilograms per hour, so for the entire time of the surgery. So why would we turn to lidocaine? Because lidocaine is a very efficient drug to block pain, but it was considered as a local anesthetic. So, but the fact that we used it intravenously, thanks to the Millier's recommendations as a French professor, well, it proved to be efficient in combination with dexmedetomidine and that scheme that I mentioned earlier. So why dexmedetomidine? So we tried to do it without this drug, took ahead with our method, but without the use of this component, we would see the increase of the cortisol. But when we administered dexmedetomidine, then the cortisol would be normal. So why, again, dexmedetomidine, because, well, it binds and activates alpha-2 adrenal receptors, which are in the brain, and inhibits and releases synaptical bubbles, which brings to the inhibition of the receptors, which also inhibits the pain and relieves of the anxiety. So dexmedetomidine is not an anesthetic in itself, but as a component for the anesthetics, which actually activates the activity of other analgesics, it could be used very successfully, not only in our clinic, but elsewhere. So now look at the hemodynamics of the bispectral index of our patients. So as you can see, no changes from the point of view of the hemodynamics, no decrease in arterial pressure or the heartbeat frequency or any other parameter in these doses, in this was not detected. And so only the patients who got the beta blockators, they were the exception, because we saw some the activity of the beta blockators, and part of them we saw the decrease of the heart frequency beat to 52, 53, and so this group of patients, you have to be very careful if you won't decide to use this scheme to them. And also the index of the vascular resistance also goes down, which is good on the one hand. The index of the periphery resistance was low, but nevertheless this would lead to the fact that to regulate the vascular tonus, you have to use a lower dosage of this drug. So now the results of this research showed that the blood circulation indicators proved to be normal, and also positive verbal contact with the patients was established after 18 minutes, and all patients we extubated within first 3 hours after the surgery, and by chemical indicators of gases in the blood was normal, and none of the patients talked about any integrational events or any side effects. So you can see the trends of the analysis of one of the patients. This is just an example of the absolute stable hemodynamics. So, and then also the cardiospecific ferment indicators are within the pathological norm, so we didn't see any increase of this indicator. So this method did not have any adverse effect on the myocardium. So, and the cortisol level in the early post surgery stage was 479, which is within the norm, and which speaks for the absence of the stress activation of the cortisol. So in the after surgery period, we saw some advantages of this methodology in terms of the lower need of our patients for the opioid analgesics in the early stages, early post-surgery stations. Well, our Scandinavian friends use somewhat modified scheme, and this is an example of what they are doing. So intraoperational introduction of the highest doses of opioid increases use of morphine, and as a result the constant pains after the surgery, and also this kind of anesthesia, from my point of view, anesthetics is good for the patients of who are advanced in age with the neurological pathology, who are in anamnesis have different um, deficiency of the cerebral function. So this will be well, the overview of our use of this methodology, and I'd like to thank you for your attention. Thank you. I believe that we have accomplished all what we had in our agenda, and of course we apologize for being behind the schedule, and we've been expected, and would like to thank everybody who presented today. Thank you so much for the audience, for being so patient. Good health. the program, and then I would like to give the floor to the first speaker, Mr. Kim Dmitry, so from Tashkent, from the Republican Center for Emergency Medicine, and will speak about the evolution of vision on the patients with the thrombosis for the 20 years period. Good afternoon, dear colleagues. First of all, I would like to thank the organizers of this conference for this center. I would like to share our opinion on the treatment of the thrombosis patients in the period of the last 20 years. So, and of course, it's a very urgent problem, and then the frequency of the venous thrombosis is registered within 1.5 events for 1,000 population, and with the complications 60 publications for the 100,000. Why is it we chose this fragment of the vein? Because this is where the embolia takes place, and then so we talk about the 80% of all cases. So when we talk about the frequency of the patients of the thrombosis, this kind of thrombosis, so we would talk about 5-6% at the traumatology and gynecology departments. Mainly. So of course we had an aim to have the retrospective analysis of the treatment of patients with thrombosis, and based on the data to design an algorithm of a treatment. So what you see here is the hospitalization route. So of course most of the patients came on their own, and with the advancements in the ambulance, we had more patients that were brought by ambulance. So if we talk about the patients with the deep vein thrombosis, so we have the parity in terms of the gender balance, but age-wise we had mostly patients within the deployment range. So the concomitant pathologies and Richter factors, so we could mention the cardiological diseases, which is up to 31%, and among these risk factors is the excess weight and obesity. So we had the following studies. First of all, ultrasound of the deep veins, which is of course still the golden standard of diagnostics, and it's non-invasive and allows to conduct a dynamic observation of the patients. And of course we also use the retrograde, and of course we have the angiopulmonography and the gametology. Also we did some research on the thrombophilia of the patients, and in the future we analyze that all the treatment that we administer. So why is this a golden standard? Because as you can see here, so diagnostic value based on the thrombosis, so sensitivity is up to 97% as to the localization level of thrombosis. So this methodology showed the 100% result when we had the thrombosis of the lower limb veins, and then so of course elsewhere the sensitivity of the methodology would go lower. So we introduced the invasive methodology of study, the contrast X-ray and angiopulmonography.
As it was mentioned earlier, we made genetics molecular survey. We studied prothrombin gene defects. And upon the results, on the basis of the results of this survey, it was revealed about 79% of patients with thrombosis of deep veins were determined at least one mutation out of 3 genes, and that's the result of the survey told us that after inpatient treatment, patients were prescribed prolonged tablets anticoagulant drugs. And during 20 years of our center in vessel surgery, and we comparatively split them into 3 groups, and this is the period. First group from 2001 to 2002, 120 patients conservative treatment, and second group included 1,793 for the period from 2003 to 2017. And here we split it not by localization level, and here that we see that patients and that left side localization we encountered much more often. Second group as well, they were diagnosed more than 6% with thrombosis embolia, and on this slide you can see that it's more for proximal segments and right side localization. Of course, it's related to anatomic peculiarities of the body structure. And for the second group, more active surgical tactics was applied. About 20% of patients were subjected to surgery. And it's necessary to mention that in line with our observation, 20% of patients subjected to surgery, there was an increase of thrombosis in proximal direction, which made us to utilize more active tactics. And the third group includes from the period of 2018-2020, 418 patients, and localization level is on the The third group included 418 patients for the period from 2018 to 2020, and was diagnosed about 13% of the patients with episodes of thrombosis lung arteries. So this part considerably increased in comparison with the previous group. So maybe it's related to more severe state patients after surgery on oncology or trauma pathology. It's necessary to mention that the most part of thromboembolia episodes were related to right side localization of thrombosis. And activity for this group increased. It has almost reached 35% for the patients who took care, and we can see surgery activity prevails over conservative therapy, and the conclusion was made that it leads to increase without waiting used to utilize much more active tactics, and so we reached more localization. And the list of surgeries made it is necessary to mention that only in our center we make surgeries with main pathologies with thrombosis comorbidity and accompanied with traumatologists team with the clipping of the bottom vein, and with cardio surgical team we made 6 surgeries. We made prevention of repeated thromboemboli and also thromboectomy. So standard surgical access. This is intra-surgery picture and ligation. Here we can see ligation of the vein. Here plication and making collectors and cover clipping based on method of the clinic. And thanks to this device, it's extravenous and doesn't damage endothelium of the vessel, and helps form equal collectors to hold different cover filter modifications were used in post-surgery complications lethal rate. And on the basis of above mentioned, here we can see simplified algorithm. So briefly, here we made a conclusion that thrombosis and episodes of thromboemboli of lung artery were the main reasons for and in line with our observations and literature. Thrombosis were observed for 8% of episodes. And clipping was a reliable method of TO prevention without using expensive equipment. And in 20% of the cases there was a growth which made us to use more active tactics. And thank you so much for your attention. So okay, discussion will be at the end. So next speaker please. And next is dedicated to mechanical complications of stroke, myocard stroke, professor from Chisinau city, Moldova. Meanwhile, I would like to thank our organizational committee. It's an honor to be here in Uzbekistan with you. Thanks for the manager of cardio surgery, Mr. Abdusalam Abdurrahmanov, for this invitation. We had very intense 2 days of surgeries, of discussions. We shared our experience, our opinions. I would like to say that cardio surgeries team is pretty adult, so I wish them success in the future work. I would like to share my experience, our experience of the clinics here in the presentation. It's mostly my personal experience where I worked and made such surgeries. It's usually said that myocard stroke is mostly the problem of interventive cardiologist, but in line with American and European recommendations. There is a huge field of work. For example, there are special pathologies when there is a need to perform surgical treatment. Here, the last recommendations of European Community of Cardiologists and cardiothoracic surgeries, and there are main precautions for surgeries in cases of acute myocardial stroke, but the main problem is by so-called heart team, which makes decision on which kind of treatment is applicable to a specific patient. Here, after coronary surgery, surgeons and reanimatologists are invited in order to discuss what kind of treatment is more convenient for a patient that should be applied. And here it's already developed precise algorithm, and one of the burning issue for treatment of acute myocarditis stroke. These are mechanical complications. I don't know if there is a PowerPoint. And you know everybody about wide spectrum of complications after acute myocardial stroke. Clinical complications which should be carried out, obligatory surgical treatment, and among those which are precisely classified, it's aneurysma, acute ischemic disorder, and heart breaks. Aneurysma of left heart section. We make surgery in the cold period very often, and after a scar within 2 or 3 months after surgery. But sometimes we need to make surgery with serious, or for patients having big thrombosis in the left part, or with patients with suspicions for pseudo-aneurysma. And the history of surgical treatment of the left side is more than 60 years. And here you can see the main stages of development and surgeries, and now such surgeries are described pretty well, and there is experience of practically all the modifications, and it's very important to understand which form aneurysma of left side, where it's localized, and if there is a thrombosis in the cavity of left, and the dyskinetic aneurysma of the left side, or akinetic. There are such diffuse forms. They are the worst, since all myocard suffers in most often cases localization of the front wall, about 60%. And we divide it into front, into lateral, into rear aneurysmas, and different localization and diagnostic criteria includes standard set of pre-surgery surveys. This is first of all clinical checkup survey with use diagnostic methods of cardiography. Screening is very important, colography, and there is a pretty wide use, and we receive lots of information from radiologists, from an intervention radiologists with the help of MRT. And nowadays, with the help of new technologies, we have very good results, and we can make right decisions in order to choose the right type of treatment. What type of patients are subjected to surgery with aneurysm of the left side requires surgery, because as we know, these patients are decompensated pretty fast, and that's why there is a need to apply surgery. Patients with stenocardia or with indication of heart failure or the risk of development of myocarditis. What are the main principles and the most modern the options geometrical or functional reconstruction of the left side when it's open along all the scar length, when there is a thrombosis which is removed from the left side. And I work pretty aggressive on the structure. We always check the distance between muscles. That's why I apply different tactics for papillar muscles in line with the class or Nair, using pieces of pre-blood prosthetic, or we use experience of such surgeries, more than 80 surgeries, and after surgery was completed, there is a stitching, and after that left part is stitched, or there could be direct stitching applied if wall is steady enough with the use of Teflon pieces. Here we can see a short movie, a clip of the techniques of the left side. Here it's so-called Fettin stitch, circular remodeling, in order to get closer to make to have edges of a live myocard closer, and to exclude scar myocarditis. This is usually performed by stitching, and sometimes we use a meter in order to measure volume of the left side, but having information on the basis of MRT data, we use it in intestine echocardiography, and on the basis of this we made a conclusion on what should be the difference distance and what should be a defect, and so in this case patching is applied. And the experience of these surgeries is pretty intense. We have just counted only those patients who received all the checkup and MRT. We can see different techniques of surgeries and majority of operations, and for all the patients multiple revascularization, and pretty often total vascularization, as it's typical for patients of young age. Results of surgeries are good. We can see as left part, cranial part became smaller, lethal rate is less than 6%. Paying attention for those patients are from severe groups, and the results are up to 10 years, demonstrate high survival rate, about 99% of the patients, which is, correlates to the data of the literature.
So the ischemic mitral regurgitation, which is quite frequent, up to 10% of all cases with AMI, and most of the patients, so we see these mitral regurgitation, and then looking at the survivability of the patients with the IMR, it's much worse as to patients without it. In the after surgery period. That's what it looks like, the mitral valve. So you it will be caused by the total, the rupture of the capillary vessels, and with a huge, rather large ischemic myocard area. So this is what the rupture looks like. So what we do the reconstructive surgery. So for these patients, it's the only chance for them is surgery, and of course it's always acute cases, and you have to operate as soon as possible and revascularize as long as possible. Lethality is still high, but nevertheless many patients have additional chance, because otherwise they would have been condemned to death. Nevertheless, this is a prosthetics of the valve during the bypass grafting. So this is the methodology we have designed in our clinics, annular plastals. So, and we have operated 37 patients with the rupture of the mitral valve, and the mortality is 6, and 4 of them because of the interventricle membrane. So, and of course ventricle septal rupture, VCR, develops in the second week, the first 2 weeks. So, and then we have to do the examination as soon as possible, the intensive care unit, and including the ventricular graphy to exclude noises. So we have to deal with the frontal ruptures, and unless operated, patients will die rather quickly, and it's quite a serious aggravation of the IMI. So 25% die within the first 24 hours, within first week 50%, and after the month 80%. Therefore surgery is the principal treatment. So if patients live longer, that is great. What we see here is a chronicle rupture with the clear-cut edges, so you can do the surgery. It's much more difficult when you have the acute complications with the soft walls. So I'll show you a very short video, then surgery on the women, 60-year-old woman with a rupture of the back wall. So we did let me show you the film to save time. So this was the rupture of the intraventricular membrane. So it actually was fragmented into slices, and it would be very difficult to do the operation from the left ventricular, because we go through the infraction area, but we have to find the non-traditional access from the left ventricular because of the nature of the damage, and then this tissue were very soft, so we have to go look for healthy cells for our needle. So that's why we opted for this non-standard methodology. We put one patch, we strengthen the intraventricular membrane, and then put another patch and yet another layer to strengthen the membrane. We added the biological glue to fix the membrane. So basically we created a new right ventricular, so we have to make a patch with a piece of bull pericard to make sure there is no leakage, and there are two-line stitch to have this camera. So patient recovered very quickly, and she was intubated on the second day, and on the sixth day she went home. Now conclusions. Mechanical complications of the acute myocardial infarction are indeed severe. Patients, and of course here we see very high mortality, and the forecast in these cases is quite bad, ominous, when treated conservatively. So surgical intervention is the only chance for survival, and these operations had to be understood because each patient has an individual situation, and then the complex understanding, complicability technique and technology, and of course experience. Although the operative risk is high, but nevertheless this is the only chance for these patients to survive. Thank you very much. Thank you for very substantive presentation. So next one about the heart and lung resuscitation, and the availability of defibrillators.
Time meet with patient who fell down with cardiac arrest, emergency physician. If we have time, and if we organize the emergency system, we will increase chance for the survival. Now I will talk about successful cardiopulmonary reanimation hospital in Vienna, and what is important if you have 80 defibrillator on the street. Very bad. A lot of people on the world die and haven't chance for use a defibrillator in the house, in the street, and must waiting emergency physician. Time to time we have very traffic public transport like in your country, like in my country, like your street or your country, public transport is full. We haven't time to time, we haven't time to come for 10 minutes or 7 minutes. If we have defibrillator on the street, on the bank, on the one shopping mall, we will increase chance for the survival. And this case talk about patient is my age, sorry, 47 years old man who will stay in his house with the daughter. Started nausea, vomiting, sweating, I don't know, and he told the doctors I have a big pain in chest. And after I don't know how many minutes he fell down, and daughter started to press chest, and daughter called emergency. What is important? When daughter called emergency, and dispatcher center tell we haven't emergency car. Emergency car is very far. And who is react? React the police, because in Vienna, in Austria, police car, patrol car, have 8 defibrillator in the small 8 defibrillator in the car. When police come, put it defibrillator on the chest, and deliver it 5 shots. After 5 shots, emergency pick up patient and deliver a patient in the hospital, ordinated therapy, and this patient when come in emergency department have 3 episodes for ventricular tachycardia, and this ventricular tachycardia also we regularized with the medicaments. When transport patient in and make PCR, this patient have occlusion on left coronary artery. In the left coronary artery, we put it stents. This is EKG tape after the stents. And when you have very long cardiopulmonary reanimation, a rule in Austria, in AKH hospital, when I spent time on observership, like Dr. Abdusalam, rule is after long time for the reanimation, all of patient after have put on the hypothermia and use hypothermia and put the temperature down 24 hours, because neurological outcome after hypothermia will be the best. During an observation, we make CT, MRI, and everything is okay. Echo also. After observation, patient delivered or internal units, and patient survived. And who helps him? Police. Next month in Montenegro we will have 20 defibrillator on the 10 cities. This is the One Europe project, and we will have every city will have 2 defibrillators. It's not enough. If you have 2 defibrillators in this city, it's not enough. This is the program, and we will try to developing, and in the future we will have a lot of defibrillators on the street. I don't know how is the situation in your country. In my country, we have deficit for the doctors. Doctors don't like work in emergency because job in emergency is very heavy. You spend 12 hours or day shift, night shift, and we have deficit. We must start to study to study paramedics, or we must start educated police, fire brigade, and another or people how to use a defibrillator. Because we increase chance for survival. Thank you very much.
Спасибо за содержательный доклад.
Thank you very much indeed for the most interesting report. It is indeed a great pleasure to deliver the and I will do it in English.
Обладает этой системой, этой специальностью, а это предполагает тренинг, это предполагает учебную программу в области экстренной медицины, и существует соответствующий квалификационный экзамен, и специалисты должны сдать этот экзамен, чтобы поддерживать стандарты врачей экстренной медицины на должном уровне, то есть состоит он из теоретической части, ну и из практической, где есть ряд симуляций, ну и, конечно, результатом экзамена. Значит, программу европейскую, приводим ее в соответствии с последними стандартами, ну и можно сказать, сама экстренная медицина в системе сколько.
And all this time is crucial, and emergency medicine physicians know how to work under time constraints and under stress and under several aspects of emergency medicine, and how to take care of several patients at the same time. And emergency medicine was recognized on the European bodies and the European UMS and the European Commission in 2005 as a full specialty, as accident and emergency medicine specialty. And since that day, all other countries have registered
несчастные случаи, например, и так далее. И вот 36 стран, они входят сейчас в эту ассоциацию, и Многие из них, собственно, дали статус, большинство из них дали статус экстремедицины, статус медицины. Ну и видите, у нас как еще большее количество ассоциированных членов. Мы очень много мероприятий проводим. У нас есть, мы разделены на секции, на комитеты, которые покрывают широкий круг вопросов, которые находятся в нашей юрисдикции, и так или иначе подпадают под различные подразделы экстремедицины. И мы тесно сотрудничаем, работаем с другими ассоциациями, педиатрической ассоциацией и так далее. Ну и вот мы проводим конференции, мы проводим мастер-классы для молодых специалистов. И вот в 2022 году мы возобновили наши офлайновые курсы. И хороший журнал мы очень публикуем, который так называется, Европейский журнал медицины. Статьи, опубликованные здесь, очень способствуют улучшению эффективности лечения. И, конечно, у нас есть свой съезд, ежегодный съезд. Ну вот некоторые фотографии с этих встреч. Более 2500 кандидатов у нас использовалось на виртуальном нашем съезде. И в этом году в Лиссабоне у нас очередной съезд. Ну, и, конечно, это хорошая возможность не только поучаствовать в диалогах, но и хороший способ установить рабочие контакты. Вот, собственно, как раз. Ну и, конечно, хорошо провести время. Приобрести много новых друзей, с тем, чтобы вместе работать.
В этом году это первый конгресс был и у нас было очень продуктивное время. Мы проводилось очень много взаимодействий, несмотря на вот текущую ситуацию. Да, я знаю, что ситуация в восточной части Европы но довольно сложной по сравнению с Южной Европой, но в любом случае возобновлена, конференция опять начинается, и мы работаем усердно над тем, чтобы проводить конференции. Вот в июне этого мая в Греции проводилась конференция, и в следующем году также мы всех приглашаем на этот конгресс для того, чтобы обсудить проблемы экстремедицины, с которыми мы сталкиваемся каждый день. У нас день экстремизма.
We had lots of different activities and lots of successful activities. This year, more than 71 million people have seen some of our activities, some of our posts, our videos. Lots of people have put their pictures on the application, on the website. So we're really happy with that, and it's getting more and more attention from the public.
Здравствуйте, уважаемые коллеги! Это большая честь для меня выступать впервые на съезде Ассоциации врачей экстренной медицинской помощи Узбекистана. Как мне сообщили, В этом году вашей системе экстренной медицинской помощи исполнилось 20 лет. Позвольте мне поздравить вас с этим достойным юбилеем. И я от
with
всей души желаю
this anniversary, and I really wish to my Uzbek colleagues a further success in this noble activity and for the sake of this beautiful country. Due to the time limits, let me start with the subject of my speech on how the system of emergency works, where I live and live 26 years and work as emergency specialist for 16 years. Emergency system is drastically differs from the territory of ex-Soviet Union countries and from European models, and the main three key differences is there are only paramedics and emergency doctors are only at inpatient facilities at any hospital. This is the most rational approach in our country, where doctors are the most expensive elements of healthcare system, and it's pointless from financial point of view. And nowadays, in order to provide qualified help in line with modern standards, high-tech equipment is required, and it's impossible to have it installed in an emergency vehicle. Another aspect is that there are no emergency hospitals with SMP in the USA. All the hospitals of general profile, and every hospital has inpatient facilities with specialists. These are diagnostic resuscitation and stabilizations of any states, making decisions on further treatment, hospitalization. In this case, patients have planned or emergency treatment with any consultant, can be called to emergency department using pager, and must come on the first demand. Here on the slide you can see a typical inpatient department in any at any average United States hospital. Now, emergency vehicle where paramedics work from the place of the accident or from home using 911 system, aviation team using helicopters from the place of accident or by a transfer. Patients can arrive to the hospital, which is the most stable category, can get to the hospital by walk or by car. For example, a patient's state which required emergency intervention. In this case, they are sent to the hospital, and police can deliver patients to our emergency department if there are any grievous accidents or shot wounds. When expecting of emergency vehicle can result in lethal outcome for a patient. Here we can see our typical components of emergency department. Of course, number of rooms and quantity of doctors depends on the workload of hospitals, and department is located the way for emergency vehicles, and civilians can get simple and easy access to the department. Here we have triage, registration, trauma bay. This is the part of our department where trauma resuscitation, X-ray, CT rooms in some hospitals. Nurse and doctor points, patient rooms, auxiliary facilities, and obligatory security posts. responsibilities of emergency doctor, as you can see, are the following. This is receptionist checkup of all patients we cannot deny. Timely diagnostics of emergencies, state resuscitation of critical patients, standalone or in cooperation with consultants, stabilization of acute states, training residents and nurses, direct control of treatment, all the prescribed procedures, providing constant work and coordination of all the resources utilized, like paramedics, bed spaces. So these are the stages of this complicated system. We also make transfer to other hospital if required, and prepare documents, death certificates if there was a lethal raid. So your question, what is the specter of patients of emergency states? We are very proud by of our motto, anybody, whenever, 7 days a week, 365 days a week. We treat everybody, all the diseases, without gender discrimination, without age discrimination, gynecology. Of course, we do not provide definitive treatment all the time, because if there is acute appendicitis, surgeon is required, or in cases of intervention cardiology, by primary stabilization and diagnostics is on us, and diagnosis is already done, and in these cases surgeon is invited to a surgery theater. There is very short list of what we do independently. We can make thoracotomy and tracheal intubation. We make by passing open drainage of abscesses, stitching, perimortem, cesarean cut, ultrasound diagnostics, arteriocentesis of all the vessels, almost all the vessels, and delivery. After providing the required treatment to a patient and required diagnostics and treatment, the result of the stay can be the following. Patient can go back or receive to the inpatient facilities or transferred to another hospitals, or in case of lethal raids, we of course prepare death certificate sent to the morgue. Of course, we try, we do our best to cooperate with colleagues, but on my territory, I make decisions. This was the very short overview of emergency system in the United States. I really hope that it was interesting for you and you received useful information for yourself. And I thank you so much for your attention, and I really hope that next year we can see each other face to face, physically, in the at the same place. Thank you very much for information. And the next speaker report is dedicated to acute surgical aorta pathology, modern diagnostics and treatment. Aurelian Andrian Rotaru from Chisinau, Moldova. Dear colleagues, aorta surgery, aorta pathology, this is one of the main acute burning problems of modern medicine, since it's related to a high lethal rate. And in such cases, with such patients, there should be direct and fast actions. That's why elementary knowledge is required for almost all the doctors. And of course, vessel surgeons should know how to treat such patients. Most probably in parallel with acute coronary syndrome, the state acute aortal syndrome and aortal pathology, and some of the states should be treated very fast without delay, and some pathologies are chronic, and sometimes there could be complications, and between them the group of such pathologies which are both for acute and chronic states. The most transthoracal transesophageal CT or MRT, and much more seldom in acute situations aortography is used. What we want from our radiologists to help confirm diagnosis, to classify and to define spread of dissection, to reveal precardial, to define the level of aortal regurgitation, and to know how to which extent coronary vessels are involved, and what is the state of sides of aorta or branches of abdominal aorta, because mostly it's related to malperfusion syndrome, and there should be fast actions. And aorta sections, there are a few ones, but from the practical point of view, this is classification by Stanford University. This is type A and type B. And type A, when aorta on all in any section at any section of extent, or when the dissection starts lower in the bottom part of artery, it's necessary to keep all this classification in mind, because this becomes the basis for tactics or strategy of patient's treatment. Most often CT is utilized. Almost all emergency departments or specialized departments are equipped with this equipment, or at least transthoracal is required, but the most specific and preciseness of diagnosis is normally defined by CT. A patient with suspicions for acute aortal syndrome should be subjected to echocardiography as soon as possible. If cardiography specialist is experienced, in most cases he will determine, he will say that there is an acute dissection and there should be immediate actions, and additional educations such as expansions or aneurysms of aorta, or related to the extent of aortal regurgitation, and if there are no any other explanation of the reasons why there is a development, and having opportunity to make echocardiography, it shows dissection much more often, and on this basis we can evaluate the spread of dissection if it goes to the upper or to the bottom part of aorta. Angiography CT is normally utilized, and modern equipment provide very precise data, and it gives us the basis for making a decision for on further treatment. And normally, if the decisions are made to make surgeries, it's typical for type A patients. For upper part of aorta, such patients should be delivered to inpatient facilities very fast, with the possibility to make surgical intervention type B. Or the bottom part of aorta, such patients are initially treated conservatively till the extent, or if there are indications of worsening or pleural bleeding or malperfusion syndrome for limbs. And any patient with suspicion for aortic dissection, there should be measures taken, required and logical. It should be done first in order to prevent lethal outcome and damage of life important, and approximately 1 or 2 persons die every year. There should be very aggressive hypertension treatment, intravenous with using opiates. It's done in parallel together with diagnostics in order to set the final diagnosis. And the set of the therapy is to reduce pressure down to 100-120, obligatory use of beta blockators, and if pressure is not decreased, nitroprussine, but it's used together with beta blockade. And candidates for surgery are type A patients or type B patients with complications. And aortic surgery in acute aortic cases is pretty complicated surgery, but here there should be individual decision made, since standard methods of treatment are not applicable for all the patients. Depending on the break location and the distance of dissection, here we had to make emergency surgery after heart stop. Aorta is opened, and here we can see clearly break location. Usually these are breaks type A, in the perimeter of a few centimeters upper, and then it's expanded to the different distances down to bifurcation of aorta. Techniques of surgery is liquidation of false gap and replaced section with prosthetic vessels. And one of the problems is to get connected to artificial blood circulation, and especially in cases when intervention is expected, and right bottom heart part, in some cases perfusion through the leg can be used, but in the worst cases sternotomy or cannulation.
So then you cross the aorta and then the direct cannulation of the normal aperture. So when we have the aortic valve, so what has to be done, and then because it's a very wide range of surgery, starting with the plastic operation on the aortic valve, or the changing the valve with the existing conduit prosthetics. So when we do say the AOV, then dissection at the root of the aorta if the patient is young, so we need to try to keep the valve by using a reconstructive operation or using the reimplantation or remodeling the aorta, although this surgery takes time, but nevertheless it's more sustainable for young patients because we do not use any prosthetics. So when we talk about the ascending aorta, we should know the proximity to stop the blood flow, and then or the hemiarch. We might need some additional measures to protect the brain. So it's quite high-tech surgery we're talking about. Different kind of surgical operations when you implant separate vessels, especially when you need the hemiarch. When at the end of the prosthetics you have a stent, and very often that helps to the second stage of surgery. So that's how it would look like. So there was a surgery of a patient dissection of aorta. So this is the branching methodology that helps you to put prosthetics on the aorta, on the working heart, and sustaining the blood supply to the brain. So either using the commercial prosthetics, or we make an improvised one. So what you see here is these kind of prosthetics with the aorta and the arch. Sometimes, so we ascending aorta is replaced. So do we have this Marfan syndrome? So we use the elephant trunk as the first stage, and second stage was the prosthetics of the aorta, the patients with the genetic disease. Well, it's quite frequently used surgery that is carried out in several stages. Very short video. So this is the magnification of the surgery, and this echography shows the dissection membrane. So we see the aorta regurgitation of the aorta valve. So this operation use this special methodology. I need to have the vision. You see there are lots of liquid in the pericardium, so we have to tamponade. And when the patient is in shock, you can punctuate until the artificial blood flow is established. After the heart has been suspended, you open the aorta, you cool it down, like in this case, and up to 28 grades centigrade, because it's a 15 minutes work. And once we have the artificial blood flow, we glue the aperture by the bio glue. So we have different kinds of bio glue based on the formaldehyde glue to glue, and then also the clips, different clips. So and then we saw using the sandwich technique when we use a Teflon membrane from the side of the intima to have more robust walls in case when the wall is too soft after the anastomosis. We do the blood flow, then we start heating. So once we did the distal, the proximal part of the arch, well, the blood circulation was suspended, and thanks to the hypothermia, brain is intact. So it depends how deep is the dissection of the aorta. Sometimes the aorta sufficiency is caused by the loss of sinotubular junction support, and therefore when we remove this aperture and then we glue it, then our outer valve is put in its place, but it will need further reconstruction surgery on the aortal valve. So again we use the glue. Now we put the proximal anastomosis. So we use Teflon material to make sure that there's no rupture or the aorta walls. Once we've done the duration, so we release heart. Fortunately, the results in the past 20-30 years have not seen any changes despite the enhanced diagnostics, and this surgery still carries high risk, and since these patients would die within the next few months, 2-3 months, so most of them within the first few months, so surgery provides them a good chance for survival. So lethality is higher with patients with dissection of B-type. So therefore, these patients should be operated in so-called cold phase, and these patients should be followed by treatment after the surgery, because unfortunately these patients after the well-performed surgery go back home, and nobody really watches them, and the frequency of redissections is rather high, and then a great number of deaths is actually could be explained by the fact that these patients are not followed and they do not receive adequate treatment with these pathologies. Thank you very much. Thank you for the most interesting presentation. Maybe there are any questions in the audience. No questions? Well, the next presentation from St. Petersburg, Platonov and Alim Hojayev. endovascular opportunities to treat critical ischemia of lower limbs. Good afternoon, dear colleagues. Unfortunately, the author of this work could not make it, so I will try to make a presentation. So we talk of the endovascular opportunities when we treat critical ischemias within the multi-disciplinary approach. Well, the patients with this in this situation very often prompt endovascular interventions because of the damage of the arteries of lower limbs, and then so the shank damage, so actually 98% of cases, and then occlusive of one of the arteries at least, and half of them occlusia of all shank arteries in most of the cases, so these occlusions are quite prolonged with the further prolongation to the foot, and unfortunately on the foot as well. Well, the arteries would be occluded, so 85% of one of the feet, and well, 35% would be the arteries of both feet. In 65% of the cases, this occlusion of the feeding artery. So, in other words, the key importance of the ischemia of the lower limb is caused by the failure of small vessels. So to revive blood circulation, well, is a recommendation to treat this condition that can result in the loss of the limbs. So revasculations is a solution that had to be regarded. So we talk about CD 3 and 4 in accordance with the Wi-Fi classification and vascular evacuation with angiosamic also. So if you look at the clinical cases, we have this necrotic damage of the foot and of the heel in accordance with the guidelines. Artery had to be recreated, and so we have good and realistic results. So case 2, when we do not follow the amniotic principle in the distal part of the foot, and then so
we have good clinical and geographic results, and it's very important when planning a surgical intervention to understand which anatomical structure an option should take place. There are 3 types in line with classification. Let me skip them. What are the methods of localization we use? Of course, it's logical to make internal recanalization of arteria. You can see the process on the slide of intraluminal localization of front and rear arteries with the recovery of arteria with good angiographic results. In cases of failure with intraluminal localization, we make subintimal free from arteriosclerotic material. Here on the slide we may see the process of canalization formed by the loop of with the excess and good angiographic result. Here on the picture, Alexander Vladimirovich Jalkovsky. These are CT. This is CT data, highlighted and visually demonstrated angioplastics, formed subintimal gap. True gap is moved aside. In case of failure, we reintegrate. We utilize retrograde recanalization techniques and retrograde access. Feet and the bottom part of a leg. When retrograde loop methods can be the choice. It was mentioned for retrograde access. We use in cases of antegrade access and inability to use loop methodics. We make access on the basis of roadmap resume or under ultrasound navigation. Let us see the options of retrograde access. A patient is traffic changes, occlusion of all the leg arteries. In this case, intervention was not successful, and recanalization attempts in integrate manner ended with perforation of all arteries and collateral breaches for use retrograde loop techniques. But here we can see segments of arteries which are applicable for retrograde access. There was a puncture of medial arteria, but there was a shift to we performed the function of artery, and there was a double excess for entire system, so we successfully made recanalization of rear part arteries, and the next we can see restored rear arteria. But paying attention for localization of trophic changes, we understood that angiosomatic revascularization was not performed, but now we have opportunity to utilize retrograde techniques and retrograde direction. Subintimal recanalization was performed with a good angiographic and clinical result. It's necessary to mention in conclusion that endovascular intervention can be done again and again. For example, 65 years old female patient with a distal artery and with a limb restoration for 11 years. There are 12 angioplastics were performed, so she can use her legs. And duration without repeated cases, more than 2 years. Thank you very much. It's very interesting speech. And now we are coming to our last speech from Germany, from Charité Clinic. for Berlin. Dr. Bernweiss with the telemedical support between hospitals and clinical aspects presentation.
Without mentioning Future, a project in cooperation with the Republican Research Center of Emergency Medicine, RRCEM, in Tashkent, Uzbekistan. And my very, very special thanks go to the colleagues in Uzbekistan and their support of this project. I would like to explicitly mention Professor Kikmat Anvarov. So what is Future? Future is a joint project of the German Public Health Institution, Robert Koch Institute, and Charité, together with RRCEM in Uzbekistan, and between our excellent institutions. So one real challenge of the corona pandemic, which was actually seen pretty fast, is the vast amount of evidence that is generated. What kind of medication should we use to treat our patient? What kind of ventilator settings are more beneficial? Is non-invasive ventilation better or invasive ventilation? If you just look at the PubMed hits for intensive care and critical care in 2020 to 2021, you find nearly 100,000 publications, most of them controversial. The papers published to the bedside of the patient, so you need something to happen there. If we look at intensive care in Germany, we have over 2.1 million cases per year and nearly 500,000 ventilations. So these patients are not all treated in academic centers, but most of them are treated actually in small and medium hospitals. And this is also true not only for the normal ICU cases, but also for the ventilated ICU cases. So especially in COVID, where the treatment is challenging, we need to make sure that the evidence comes to the bedside also in these hospitals. So the Nuffield Trust already before the pandemic wrote that we need to rethink our acute medical care in smaller hospitals and need a shift from an all or nothing principle to more of a modular approach, and we need a support chain for these hospitals. We established a round and response service 24/7, 365 days per year with a telemedical card, and we developed a structured round along QIs, so quality indicators of intensive care medicine, that allow us to assess a patient remotely in another hospital, to give tips for the treatment, to check whether quality indicators are fulfilled, and to also in the end enhance the recovery after intensive care. This was actually the project's name, ERIC, Enhanced Recovery After Intensive Care, and the project was just finished when the pandemic started. So during the pandemic, we scaled the project, and when the project with 11 hospitals came to an end, we scaled it to 28 hospitals in the city. We connected all of these hospitals to a hub center here in the middle of Berlin in the academic center. And the specialty is that it was not only one hospital company, but it was all hospital companies. All level 2 clinics, which were the first line clinics for COVID treatment, have been equipped with telemedicine. Now let's take a look how the telemedical round actually looks. So we're doing the telemedical round from a hub center at Charité, where a doctor sits, and this doctor has access to a robot. And the robot on the remote side, which can be seen here, is assessing the patient in the hospital. Sorry. So we can interact with the colleagues on site, can interact directly with the patients, And we can also take a very close look at details like pupils, ventilator settings, or the medical record of the patient. That gives us a very good and deep insight into how the treatment works, and the recommendations can be made at the bedsides together with the treating physicians. International powerful partners that would like to be connected to our e-health system to also be multiplicators, not only for knowledge, but also for digital medicine in their countries. So the first country connected to the e-health system was actually Uzbekistan, and the second country connected was South Africa. So in Uzbekistan, currently 2 machines are available, one in Zangiota and one is in RRCM. And we do scheduled telemedical rounds every day here from Germany together with our colleagues and friends from Uzbekistan. This is an example for such a telemedical round. As you see, this is the machine. This is Andreas Edel here, one of the doctors, together with Alexandra Becker, who will just be visible here. And this is one doctor from Germany, Dr. Karen Steinecke, who is just introducing that to Zangiota. And you can see we're directly at the bedside and discussing the different options. So at the moment, we do 30 consultations per day in 38 ICUs connected to our Uzbek Ministry of Health that is strongly supporting the project. I would like to say thank you to the Robert Koch Institute in Germany that together with the Federal Ministry of Health in Germany is very much supporting this program. Thanks go also to Fraunhofer Focus, who support us in our technical installations. And I hope that we will manage this pandemia together, that our telemedicine program will help us to go through the waves. I would like to say thank you. I hope you enjoyed it and have a wonderful conference. Thank you very much.
Спасибо.
Программа у нас уже так закончилась. Спасибо большое всем докладчикам. Если у кого-то есть вопросы или
Any questions or comments, please feel free to ask or to speak out. No, or everything is clear. Yeah, all people are tired and want to have some lunch. All right then. Thank you so much. Have a good rest. And see you a little bit later and take part in the conference.
as well. So our system consists of the of the Republican Center, and then 13 branches and 173 sub-branches in each district. So it's a very centralized system. So toxicological service also mirrors the system. There's a so we have one department under the headquarters, and of course all the branches have their branches, sub-branches across the country. So what you see here is our toxicology beds. Show the most of it, of course, in Tashkent and also in all big cities. And of course, recently we see the course of the past 18 years with this new toxical department, we see twice-fold growth of the poisoning, toxicological poisoning. There was some decrease in 2020, and the reason was not because people get less poisoned, because many clinics were actually transferred into the COVID. So 144,000 patients were registered. And if you look at the structure of the chemical poisoning, so that most of them would be the drug poisoning, number 2 alcohol poisoning, and recently basically this alcohol moved to position number 1. So number 3 is the poisoning by the burning poisons, and also the gas poisoning, biological poisoning in spring, summertime, and also the allergic reaction to insect bites and allergy to medications. So if you look at this age, most of them are the people in the 18 to 45 age bracket, so therefore this kind of injury, toxical poisoning, is of great social impact. So if you look at the structure of the lethality in the past years, we'll see that in 2001 the acetic acid was number 1, and number 2 was alcohol, followed by medication and the gas. In 2020, the structure of lethality changed because most of the lethality was the alcohol poisoning. So number 2, burning poisons and the like. So in the past years, we see some change in the hospitalization routes. Before, the patients would be brought, they would come on their own. So now, although it's still the dominant way of admittance, that has saw some decrease. And number 2 is the ambulance number 3, referral. So this situation changes for the better, and we see that the most of the patients, over 70%, are brought by the ambulance. So if we analyze the main ways of detoxification that I use in our department, we use the first group, stimulation methodology of natural detoxification, and also methods of artificial detoxification, and also detoxification of chemotherapy, and others. So in the first group, you will recall, we mainly washing the GIT, intraceptions, hyperbaric oxygenation. So artificial detoxification is basically hemodialysis, dialysis methodology, and sorption methodology is not used because we have no absorbents. What also is defunct in our center, such methodologies as the ultra blue therapy, non-direct blood oxygenation that is carried out in Russia, and we still have a problem that this equipment brought from Russia, and it's difficult to register them or to buy new ones equipment. So nevertheless, we saw some decrease in lethality from 3.6% to 1.8 in 21. So, and then so the number of beds a day also went down up to 1.8 beds a day. So, and we believe that what is quite gratifying for us was the introduction of the emergency medicine as a academic degree. So 1439. So I was one of the first to defend my dissertation, and then we have another of my colleagues who defended this kind of science dissertation recently. So what we see in Uzbekistan is an increase the number of toxic poisoning. So we use the modern methods of detoxification using the efferent therapy, and also we have the toxicology and extracorporeal detoxification study course at the chair of the emergency medical aid, and also we actively influence social problems. So we initiated, and of course we were supported by the foreign minister, which put a ban on the sale of the acetic acid, and fortunately now the consumers buying the Kazakh-made acid, so people didn't stop consuming it, but they found other sources of supply. So we have a new department for the suicide survivors, so where they are being detoxificated and also socially rehabilitated. So we have quite a number of problems, and one of them is the lack of chemical toxicological lab, So we all know that it is a problem, not so much in terms of buying equipment, but to find personnel, someone who possesses necessary knowledge and skills and qualification of the chemical analysis, or maybe will reinforce the existing forensic labs so that they would help us to provide the medicine, the expertise. Thank you. Thank you very much indeed for the most interesting presentation and all the problems that were discussed here. They are familiar to many people from the clinical toxicology. So what you also see that here in Tashkent, Uzbekistan, we see very enthusiastic people who are engaged in this area and constantly work, improve in order to provide better service, and also they solve the human resources problems, research, so later we show the success to these people, and of course hopefully our joint projects would be further developed. Thank you so much once again. Now the second presentation of the development renal transplantation in Uzbekistan, so Republican Center of Emergency Medicine, Faruk. Well, correction, the name of the speaker is Sultanov. Dear colleagues, so this presentation is about the transplantation of kidneys in Uzbekistan. So first of all, we have to mention that there are 4 stages in transplantation development in Uzbekistan. First is the period between 1972 and 1991, in accordance with the law on transplantation of 1970, and then there was a between 91 and 98 there was a vacuum because there was no legal basis, and the third stage the law still lacking, but there was a decree by the Ministry of Health to provide a reality. So how did it all start? So in the early 70s, the key experts started to develop this area of clinical medicine. And despite in Uzbekistan, there were quite a number of patients with the acute and chronic renal deficiency. Only in that period, the first nephrology departments and the labs of GM, hemodialysis were set up, and also back in 1971, a lab on overcoming the tissue non-compatibility was set up, and then so nephrologic problems, so the kidney transplantations were also in the agenda. There was a international expert on kidney transplantation meeting that took place in Tashkent, and Professor Aripov, Park in 1972, they performed the first kidney transplantation for the first time in Uzbekistan and Central Asia. So what we see here of patients with kidney transplantation. And of course, academicians Shumakov and Aripov played a pivotal role in the development of kidney transplantation in Uzbekistan. A new center was set up, so this is the picture back in 1983 when they inaugurated this new center. That's what we see the opening ceremony by Professor Shumakov, and then well, this center started work, and this is in the academician Aripov. So, and then well, there was a very able team that was engaged in the kidney transplantation and hemodialysis. And the period between 1998 and 2017, the development of transplantation was on the hiatus, so there were around 84 transplantation of kidneys taken from relatives, and also the rehabilitation and hemodialysis department was also set up. And in 2018, cabinet ministers decree on ways of increasing the efficiency of kidney transplantation. So the light of the day, and which also paved the way for the Republican Specialized Research Medical Center for Nephrology Transplantation, and also the chair of the nephrology and hemodialysis was also opened.
In Tashkent Institute of Advanced Medical Training. Center for Specialized Scientific Surgery Center named after academic Vahidov. Kidney transplantation surgery started, and in Republican Scientific Emergency Medical Service started successfully kidney transplantation surgeries again starting from 2017. 664 transplantation from a live donor were made. So we can see there is a trend for increasing quantity of such operation, but we can see that only in 2020 there was a slight decrease in surgeries, but it's related to the pandemic outbreak. And thank you so much for your attention. Next speech from Emergency Institute, structure of acute chemical intoxications throughout the period of COVID-19 outbreak. Dear colleagues, Presidium, I will not stop on the relevance, since the problem where the international community is facing is related to everybody, because it's turned out to be a grievous pandemic related to coronavirus infection. And as far as you may observe, the current problem, apart from medical, is economical and humanitarian as well. It impacted millions of people, made obstacles for logistics, and this is a dangerous, mortal disease. And there are negative indicators for children and adults, and coronavirus resulted in lockdown and quarantine restrictions, which resulted in dynamic of structure and intensity of consumption of different substances. and there are lots of overdoses of different drugs, including self-medication, and about peculiarities related to structure and dynamics of acute intoxication basis of our inpatient facilities of our institute, and to compare it with 2019. And here we can see that in comparison with 2019 we noticed some certain trend, not even trend, but decrease of acute intoxications receiving patients in our inpatient department related to acute chemical intoxication in comparison with 2019. We noticed decrease of hospitalization from April down less than 47% in comparison with 2020, and in September there was 58, and in November and 66% in December. Together with this, starting from April 2020, we noticed certain dynamics which accordingly expressed in increase of patients with acute coronary infections. And regarding acute chemical intoxication structure and lethal rate, here we noted certain changes which were not typical for the changes throughout the previous years. We in particular note that increased quantity of patients with acute intoxications by medical drugs and other biological substances. In addition to this, we noticed receiving patients with narco or psychodyspeptic intoxications and ethanol intoxication and other non-medical use substances. There was a trend to decrease. So we noticed increase of acute intoxication of drugs in 1.23 more. It was mainly with the sedative, sleep, and psychothrop 1.3 times. And these data are correlated with the results of the research, which demonstrated increase of acute intoxications by drugs in the as a result of self-medication and trying to cure coronary infection. High lethal rate were noted with organic dissolvents and non-aroma substances, and pretty high lethal rate was noticed for patients with acute narco intoxications, especially methadone. And regarding monthly dynamics with acute chemical intoxications, so there was no any certain specifics, and in some months there was also some difference, and mainly in resuscitation intense therapy departments received slightly more than 10%, and the peak was in January and June, and minimum was in September, November and December 2020 about alcoholic acute intoxications during pandemic. As usual, in the beginning of the year, when there were no patients with coronary infection, we had some trend during first 3 months, Nevertheless, then during the following months, there was a serious decrease of alcoholic problems, patients with alcohol problems, and decrease of receiving patients was 3.2, and daily average decreased from 40 down to 3 patients a day. We need to mention also there was a order of healthcare committee, and we changed routing for receiving patients in inpatient facilities of St. Petersburg. And about acute intoxication, as already mentioned, there was some certain increase on such as narco and psychoactive substances like methamphetamine, butyrat, and for some drugs there was some certain decrease. And as I already mentioned, hospitalization quantity in comparison with 2019 increased 1.1. Mainly it was oxybutyrat, methadone, and alpha-PVP. So main changes noticed is the decrease of alcoholic and increase of medical drugs and narcotics. And about patients with COVID, patients who were received and into the center of acute intoxications, quantity-wise they take average place in comparison with other inpatient departments. And about distribution of departments of the treated patients, so in comparison with the full scope of patients, these patients took a minor share. You can see it on this slide. And overall quantity of patients starting from 2020 till August 2021 received by Center of Acute Intoxications was 179 persons. Four departments received different number of patients, and here you can see that lethal COVID lethal rate is pretty minor. And about nosology, and there was a toxic impact of chemical substances. So that was the distribution. And to conclude, I would like to say that among distributed patients, the share of revealed with COVID-19, it was 1.12%, anti-shivering sedative 2.4%, psychotrop 2.1%, narco 1.9%, and alcohol 0.5%. And these data demonstrate the changes of the structure and viral disease resulted in uncontrolled using analgesic, and it was noted decrease of indication with alcohol intoxication, which proves decrease of alcohol consumption in spite of negative impact of virus on psychological health, which demonstrates efficiency of lockdown measures which were introduced by the state agencies of St. Petersburg, and about psychoactive or precursors and synthetic cations, which requires strengthening preventive measures in order to decrease the spread in the young community, which is a problem of international community as well. Thank you so much for your attention. Alexey Nikolaevich, thank you for your speech. As far as we may see, the COVID-19 made changes in the structure and in the quality of acute intoxications. And next speech will be on line indications of overdosage by meds and perspective of emergency therapy. Sinat Kumar. We're waiting. Сегодня меня попросили рассказать о изменениях. Это очень важная тема для всех врачей неотложной медицины. Я из Дели, я координатор группы Нараяна Хрудаяла. Я координатор общества неотложной экстренной медицины. Я рад быть с вами. И о чем мы поговорим сегодня? Мы сегодня поговорим о 5 основных причинах гипокалемии, гиперкалемия,
poisoning. So these are the main poisonings which we see in our day-to-day practice. So this brings a pleasure. So we know the common causes for hypokalemia, which is the thiazide and the loop diuretics, aminoglycosides, beta-2 agonists, adrenal steroids, chronic laxative abuse. So what are we going to see in the ECG? The potassium is very important in the metabolism and in the conduction of the cardiac systems. So you see that every part of the changes, that is the conduction, requires potassium and calcium and sodium for their maintenance. So when potassium is reduced, what happens? So we can see these are the common changes what happens. One is your slowed conduction, then delayed ventricular repolarization, then there is a shortened refractory period and increased automaticity. Then when it prolongs with the hypokalemia, then the problem is in the flattening of the T wave and with severe hyper for the membrane stabilization, actin and the conduction between the heart. So only in this condition, you should be very, very careful when you're using the calcium gluconate. Now, the next abnormalities is with the hypocalcemia and hypercalcemia. Normal calcium levels is between 2.2 to 2.6 millimoles per liter, and anything less than 1.9 is mild, and anything less than 1.9 is severe hypocalcemia. And when you look into the drugs which can cause is mainly with the EDTA tube contaminations, of which is factitious, vitamin D deficiencies and diuretics, which is the common charcoal treatment, and then immediately start these patients on insulin and glucose, because insulin, there will be hypoglycemia to overacted, you have to give glucose. So insulin is very, very useful in such patients, especially high dose. 1 unit per kg is being utilized in these patients. 1 unit means that 60 kg man has to require 60 international units of insulin per hour. That is all. But same time, you have to titrate both the glucose and the potassium levels. So that is how. The last commonest poisoning today in modern world, we all see a lot of blockade. And the second commonest feature is the patient will present with severe metabolic acidosis. The pH will be very, very low. And when you take the cardiac conduction, there is a severe delay in the QRS. And sometimes the QT is so much prolonged that the patient's going to Torsades pointers. So this is the typical ECG wherein you find with this particular poisonings. Now, we all know the treatment. Treatment is very important. Take care of the airway, breathing and circulation. Then start them on bicarbonate, which is the antidote for this. How long should you give that bicarbonate? Until the pH returns to alkalinization. That is important. And then you can see that there is a reversal of the Torsades pointers to normal QTC interval. Until then, it has to be given. The bicarb is the only treatment in case of a TCA overdose. So that is what is the whole thing about the patients coming in with a common drug overdose, presenting to emergency department with the ECG changes and a brief management. Thank you all for giving me an opportunity to speak in front of you. Our motto is each one should teach one to save more lives. Thank you. Once again.
Государственного медицинского университета Екатеринбург, Россия, Андрей Владимирович Чекмарев.
Andrei Chekmarov. Good afternoon, dear colleagues. Hopefully you can see and hear me. We can hear you all right. But you can go ahead with your presentation. Can you see the presentation though? Not yet. Can you see my presentation now? Because I have it on my screen. Well, we may have a technical problem, or maybe you should press demonstration and use Zoom software. It's a big yellow, big green button. So now choose your presentation. Still no presentation on screen. So Thank you, dear colleagues. So the presentation title is the British Intravenous Treatment Protocol with then acetylcysteine, paracetamol poisoning. So we already made this presentation. So it's more on epidemiology. So paracetamol is one of the most frequently used drugs around the world, and according to the FDA, 70% of the European population received paracetamol at least once in life, but many of them regularly taking it as an anti-fever, analgesic drug. In Great Britain, paracetamol is subscribed to 85% of children, 97% of the population, 35% of the pregnant women. So, and well, there are quite a number of overdoses in England and Wales. 90% in 1990s, it was 32,000 overdoses, paracetamols, and over 200 deaths a year. In US, overdose of paracetamol at the most was the cause of the 10,000 toxicological cases and 56,000 of cases at the ICU. Australia, it's over 2,000 cases of hospitalization. In Iceland, 18%. So in US, Australia, paracetamol is the reason of the acute damage of liver with the need of transplantation, and the figures are 20% for EU, 52% of Iceland, 28% for England, 18% for France. So now Russian Federation, there are no systemic research on paracetamol poisoning, so we can indirectly now figure out of the number in T39 group, so 4.1% per 5/6 and Ulan-Ude, and Novgorod at 12.5%, and paracetamol poisoning is 0.67%, in T39 groups 18.8%, and then in Hunter-Malthy autonomous region in the period between 11 and 15, paracetamol poisoning increased from 0.5 to 19.3%. T39 in structure drugs in the Moscow Toxicological Center accounted for 5.6, 4.7%, and also we see the increase of the paracetamol poisoning across the country in the period between 2000 and 2010. We saw the 10% increase in the patients. So this table also contains information on what I just mentioned. So you can tell in book, starting from the year 2019, 828 paracetamol poisoning. So 2.96 in the group T36 to 45, in the T36 to 55.96, and in T39 53.6%. And now in Volgograd, in the period of time between 2018 91% registered patients, which accounts for 0.94% from the number of patients. 69 in the 39 group. So now 828 patients and across different age periods, 65 between 2004, 195 between 2005 and 2009, and 310 in 2010, 2014, and 258 in 2015, 2019. So in the period between 2015 to 14, 8 patients died. So which is 2.5% of lethality, and from 2019 the treatment applied is the British protocol, which helped to bring that figure, lethality figure, down. So Jerry Mitchell and David Jallow show that the paracetamol toxicity is the result of the oxidation of acetaminophen to reactive metabolite N-acetyl N-benzohenoamine, NAPQI, so which triggers the metabolic process, and which also leads to the liver cell necrosis. And they also analyzed different medication, and then it was established that acetylcysteine is the most promising. So the dosage 30 milligram for the patient's weight, and then different journals produced study results, and in US and Canada and other European countries they use the logarithmic methodology of Rumack-Matthew, with line A, B, and C, which inform the further treatment of the patients. And then the line B, 150 milligrams per milliliter, by the decision of this agency, which is lower than the benchmark. So, and then finally C line with 100 mg to milliliter with a patient with certain hepatotoxicity. In British protocol is actually 200 milligrams for milliliter after the 150 kg dose was taken in the course of 24 hours in the chest-mate order, and acetylcysteine was also prescribed if the temporal concentration paracetamol was over 100. In September 2012, the UK Commission looked at the ACC as a way of treating paracetamol poisoning, and then so at this they have to apply the chest-mate board order in order to bring down the side effects. So what you see, the dosage of the acetylcysteine for the first, second, and third injection. So the 116 patients were studied in 2 stages. In the first stage, they established the concentration of paracetamol in plasma, blood plasma, when the patient was admitted to the hospital. On the second, they made the evaluation efficiency of therapy in the group of patients that were treated by the British protocol. concentration of paracetamol in plasma was divided by gas chromatography Shimadzu. Biochemical markers were noted. ACC was administered in 3 doses, first 150 milligrams, 50 milligrams and 100 milligrams. So all patients had the activated charcoal washout of the GIT, and it appears once after we divided our patients into 5 groups in accordance with the paracetamol concentration. So the first group is above 50% of milligrams, so we had 218 patients, and the group number 2 between 50 and 100, and the rest which is between 150 to 100 and over 300. So only 13.5%, whereas only last percentage hyperosmolar norma. And these patients could be regarded as patients with massive toxic and concentration. And concentrations of the paracetamol in blood plasma between 100 and 150 milligrams per kilogram. So we can see 127, that was the initial concentration of paracetamol, until the first dose concentration would go down to 70, and after the third one the concentration of paracetamol would go down to 77 milligrams, and then biochemistry, bilirubin, creatinine, MNO did not change much. So the patients with the paracetamol concentration over 300 milligrams, 7 of them, the concentration deviation was rather large, and once the first dose was administered, the concentration of paracetamol was on average 430 or 452, after second 440, after third one 356. A deficiency of our interventions, and so there are several publications as to when paracetamol intake considered as to be massive. So according to Marx, it is 30 grams. So I believe that not many agreed with this opinion. They said that it should start from 500 milligrams per kilogram.
Together with this in Australia and New Zealand, in last recommendation, it was proposed to double concentration. And another approach is using modified 12 hours acetylcysteine, 200 milligram for kilogram during 10 hours. And another approach was to use it for infusion for those patients with massive use of paracetamol, and it was proposed to increase third dosage to make it double or triple, depending on concentration in blood, but such a decision requires clinical check-up, which is described in the medical literature. One of the options is removal paracetamol with the use of hemodialysis, which was practiced in the 70s and the 80s of the last century. But after that, there was a conclusion made that acetylcysteine is more efficient in most cases and treating paracetamol intoxication, and with paracetamol extracorporeal methods with a concentration of more than 1000 milligram per liter, and indications of mitochondrial dysfunction and concentration is more than 900 milligrams per liter. We have some minor experience of using hemodialysis in cases of paracetamol intoxication, and you can see that concentration of paracetamol in blood plasma before hemodialysis, 3 years after hemodialysis, concentration reduced in 2 times, and after 1 hour concentration was 300 milligrams per milliliter, and paracetamol is dialysed very well, so clearance was 118. So what are the conclusions? Paracetamol intoxications is almost 3% of patients admitted, and almost 53.6 share in analgesic drugs intoxication group. So defining concentration of paracetamol in blood plasma plays determining role in diagnostics of chemical trauma, and defines treatment tactics. Implementation of British protocol within the range of concentration from 100 to 300 milligrams per milliliter secures liver from chemical aggressions. And there was also recommendation, use of recommendation of British protocol enabled to decrease lethal rate. And one more conclusion, which is not here: obligatory use of chemical toxicology survey and checkup in order to determine content of paracetamol. But unfortunately, this method is not approved. And I'm proposing to approve this protocol in order to have it approved and used in all the toxicological center with chemical toxicology checkup. Thank you so much for your splendid speech, as usual. If you permit, there is one small question. Could you please tell us, in your survey, was there standardization of infusion intoxication therapy, and what was the average volume of infusion for patients with antidotes? I can say that all the patients admitted with antidote therapy, from enterosorb washing of stomach, they had infusion therapy, and average daily volume was about 3 liters. And regarding standardization of methodologies enabling to define, to determine intoxication concentration, yeah, it's very relevant problem which Russian Federation is facing as well, and we are trying to pay attention for it, and probably after we put clinical recommendations in line with requirements, which is required by Ministry of Health and Technical Council. I do believe that the next problem we'll have to work on together in order to have chemical and toxicology laboratories working in the sector of clinical toxicology are required to be equipped with proper equipment in order to have proper evaluation of plasma concentration, in order to have a target infusion detoxification therapy, including paracetamol intoxications as well. Thank you so much. Thank you. Thank you, Andrei Vladimirovich. And we are proceeding work in our section. And next speech from the Institute of Emergency, Alexei Nikolaevich Vladyagin. And the subject is intense therapy of ethanol acute intoxications on the background of alcohol polyvisceropathy. Microphone. Could you please tell him to speak to the microphone? Which are hospitalized into toxicological centers with acute ethanol intoxication. And the next problem is that there is pretty many patients with diagnosis of acute ethanol intoxication with alcohol liver damage, and clinical evaluation of hepatoprotectors and raising efficiency is a very, very relevant issue. And this is a small survey I would like to share with you. This was aimed at raising efficiency of therapy of acute ethanol intoxication for alcohol liver damage. We took two groups, alcohol liver damage and without alcohol liver damage. And accordingly, patients without alcohol liver damage got basic therapy, which included intoxication, symptomatic, metabolic, and preventive. And the main target group with alcohol damage got basic therapy. Third group got basic plus adiamethionine, and the fourth group apart from basic got Remaxol, which includes methionine, subcyannatrioxime, ketinamide, main components in agglutinin, and some other electrolyte substances. So that's the therapy. You can see it on the slide. And regarding general description, you can see it on this slide. So mainly patients were admitted with a high concentration of ethanol in their blood, about 3.4, 3.6 grams per liter. Liver ferment level increase was observed. Expansion of liver of patients with alcohol intoxication and damage. There was also flat infiltration of liver. So regarding distinctive features of patients with ethanol intoxication and ethanol liver damage, there were certain clinical and demographic distinctions. Patients with alcohol liver damage had a higher older age, which was also related with the duration of alcohol consumption, and ratio, gender ratio was approximately equal. Distinctions were in the scale of post-intoxication alcohol syndrome. In the group with alcohol liver damage, was a KG test which characterizes availability or absence of alcohol problems, alcoholism actually, and LEGO grid, which enables on the basis of objective indications to determine alcohol consumption and period of daily use of alcohol and days of patients with damage was longer. And regarding therapy and efficiency of this therapy and indications of protein and gas content in blood. Here we can see hyperprotecting substances use enabled us to keep it in group 3 and 4, concentration of albumin at the proper level, apart from the patients who received only basic therapy, and concentration of urine apart from the group with basic therapy. There was decrease noticed in the group of diethylamine. At the same time, with the group for the group with Remaxol, there was no considerable decrease of urine. It was the same for acid state and tissue hypoxia indications, lactate. And we noticed that for the groups received therapy, there was a more efficient decrease of lactate, and the group which received Remaxol, those indicators were decreased in a more efficient way. And about liver ferment EST and the ratio EST to ALT, which is to say so, it's called coefficient of diuresis, which enables to evaluate state and the level of liver damage. We also noticed that groups 3 and 4 of the patients who received adiomethionine and Remaxol, it was approximately the same direction of trends to decrease EST and ALT indications, and diuresis coefficient changed in approximately the same way. There was estimation of indicators of oxidizing and anti-radical protection, and here it is necessary to mention that indicators of restored glutathione, so restoration process was much more faster in the groups number 3 and 4 receiving gadolinium and Remaxol, and accordingly indicators for oxidation, there was more efficient decrease in these groups. And in general, for such integral indicators, it was reflected in Apache scale and laboratory index, which uses considerable quantity of laboratory indicators and enabling evaluate morphologic and functional state of the liver, and we notice that recovery of groups 3 and 4 went much more efficiently. And all this made influence on the clinical process of acute ethanolic intoxication of patients with fat dystrophy of liver. And there was no any considerable impact by these drugs, but such clinical indications like frequency of development of alcohol delirium. These drugs made considerable influence, and together with this, the Remaxol drug, which used together with basic therapy, demonstrated much more considerable results, and frequency of development of alcohol delirium was just 12%, unlike second group with 30%. And nosocomial infection developed in seldom, much more seldom, only for 6%, and in group number 3 and number 4 it was 16 and 3%. And patients with acute intoxications, ethanol and alcohol liver dystrophy face heavy functioning disorder, and there is also liver dysfunction. Hypoprotector therapy, strengthened biological characters, keep functionality of the liver and enable clinical liver treatment, and with the increase of ILT and ST within from 3 to 5 times range, we propose to prescribe combined hypoprotector drug Remaxol. Thank you so much for your attention.
Thank you so much.
So, as you may know, fires and smoke inhalation represent a serious public health problem. Fire may expose to 3 dangers: the thermal risk, the traumatic risk, and of course, the chemical risk. When you inhale cardiac anoxic systemic injuries, so ocular and respiratory irritant injuries. You may also die, unfortunately, during smoke inhalation. 80% of the deaths related to fires are due to smoke inhalation, of which 80% occur on the scene, and they are early deaths, and 20% in the hospital, and they are late deaths. You should know, of course, that smoke represents a polyintoxication, and you see there is 2 categories of toxicants. Compounds responsible of direct cellular anoxic toxicity, including mainly carbon monoxide and hydrogen cyanide, and compounds responsible for membrane irritant toxicity, and including mainly soothes, mineral acids, and of course water vapors. This slide shows you how it was supposed that smoke inhalation is not limited to carbon monoxide poisoning. Here you have two diagrams. The first one is related to the distribution of death during smoke inhalation, and you see that there is no relationship or almost no relationship between carboxyhemoglobin concentration and the risk of death. While in pure carbon monoxide poisoning, you see that almost all deaths occur for carbon monoxide or carboxyhemoglobin concentration of more than 50%. So this study highly suggested the presence of other toxicants than carbon monoxide, and mainly, of course, cyanide, to explain deaths in fire smoke inhalation. Of course, first of all, let's talk about the asphyxiant toxicants, and these are related to carbon monoxide and cyanide. Cyanide is mainly, you see, a toxicant for the mitochondria, and it will block the aerobic glycolysis and the transport of electron in the respiratory chain, resulting in an anaerobic glycolysis with the production of lactate. Carbon monoxide will modify the capacity of hemoglobin to bind oxygen and result in tissue hypoxia. When you are in the scene of a fire, the first very important symptom is the presence of soot in the airway passages. You see here that this sign is associated with a very high negative predictive value of cyanide and carbon monoxide intoxication. Of course, you may present different symptoms, and you see that the patient with neurological symptoms could be exposed either to carbon monoxide or cyanide, while if presenting any respiratory manifestation, and mainly an abnormal respiratory pattern, any cardiovascular symptom, and mainly a decrease in arterial blood pressure, and any metabolic symptom, and mainly an elevation of lactate concentration, then you can suspect cyanide poisoning. So these three respiratory, cardiovascular, metabolic manifestations are related to cyanide and represent the cyanide poisoning toxidrome. Of course, lactate is probably the most objective manifestation, and you see, based on this study, that if your plasma lactate concentration is more elevated than 10 millimole per liter, then your cyanide concentration is toxic, more elevated than 40 micromole per liter. And you can rely on this biomarker to suspect cyanide poisoning and give the antidote. There is, of course, a quite good relationship in this pure cyanide concentration, in these pure cyanide poison patients, between plasma lactate and blood cyanide, an excellent relationship. Although, of course, there are so many factors that may contribute to lactic acidosis in cyanide or smoke inhalation patients, including cardiovascular failure, apnea, seizures, liver failure, the use of catecholamine, and of course, mitochondrial dysfunction due to other toxicants. There is also a good correlation regarding the time course of these parameters, and you see that when the cyanide is eliminated, the lactate normalizes. And finally, when you look at the relationship, the direct relationship between plasma lactate and blood cyanide concentration in individual patients like this one, you see that there is a sigmoidal relationship, meaning that at high concentrations of blood cyanide, all mitochondria are blocked, resulting in a plateau of effect. And you see that the probably lethal concentration of cyanide 100 micromole per liter correspond to this plateau, while 40 micromole per liter of cyanide correspond to the EC50 of the effect, meaning that this concentration is a toxic concentration. The second category of toxicants, these are irritant toxicants and are responsible for ocular and respiratory symptoms. Of course, with red eyes, cornea burns, but also dysphonia, dyspnea, and of course, bronchopneumonia. And the presence of conjunctivitis is predictive of an associated respiratory injury, and of course, the presence of dysphonia and rhonchi on auscultation may be associated with a prolonged hospital stay. The pathophysiology is complex, but you see that the chemicals will be responsible for epithelial injury, releasing chemotaxins, activating inflammatory cells, with exudative injuries leading to bronchoconstrictions, and of course you have a vicious circle leading to the acute respiratory failure. Regarding the management, oxygen, of course, is the major treatment of smoke inhalation patients with normobaric oxygen. In case of carbon monoxide poisoning with consciousness loss, coma, neurological deficiencies, and systematically in children and pregnant women, you should consider hyperbaric oxygen therapy. Also, as you may know, studies are really the study does not agree to support the exact contribution of hyperbaric oxygen to improve outcome. Of course, you may even on the scene rapidly discuss the administration of cyanide antidote. There are several antidotes, including sodium thiosulfate, which is efficient and safe, but with a delayed action. Methemoglobin forming agents, which are very potent agents, but may increase impairment of oxygen delivery, especially in the context of carbon monoxide poisoning. Cobalt EDTA is very potent also as an immediate action, but it has numerous side effects, and especially if finally the patient is not poisoned with cyanide. So currently in Western Europe and in the United States, the first line antidote is hydroxycobalamin, which is efficient and very safe with very limited side effects like reddish discoloration of the skin and urine and some rare allergic reactions. And it is based on a stoichiometric neutralization of cyanide. So to date, I would suggest to administer hydroxycobalamine in the suspicion of cyanide poisoning in any smoke inhalation patient, while other antidotes are not recommended. And this was also what recommended the EUSEM, the European Society of Emergency Medicine, and you see in the presence of any impairment of consciousness, systematically with Glasgow Coma Score of less than 9, with abnormal ABC, if Glasgow Coma Score is between 10 and 13, you should administer hydroxycobalamin even on the scene before hospital transfer, and then in the hospital, if not administered, this treatment should be given to the patient, and even repeated in case of prolonged elevation of lactate. Of course, you should rapidly manage the patient in the ICU with adequate ventilation because the patient will present an RDS. So humidified oxygen, bronchodilatators, mucolytics are recommended. protective mechanical ventilation if the patient is intubated is also important, with rapidly administered antibiotics, because the bacterial infection represent the first complication. Aerosolized heparin and surfactant inactivations are investigational therapies. Corticosteroids are controversial and not recommended. And of course, the patient admitted to the ICU will present different complications, including hospital-acquired infections, and of course, bronchiectasis and chronic complications like the risk of pulmonary fibrosis. There is also a risk of Brooks syndrome, which is a non-specific bronchial reactivity, which may be presented by the patient in the future years. So to conclude, smoke inhalation is responsible for an acute, life-threatening, systemic and respiratory toxicity, but also, as suggested, for a chronic disease responsible for respiratory and neurological disabilities. Smoke inhalation is, of course, first a polyintoxication. It is not limited to carbon monoxide poisoning. And of course, cyanide plays an important role and should be suspected based on the toxidrome, the cyanide toxidrome, directly on the scene and immediately treated, because it may often contribute to toxicity and lethality. And to date, hydroxycobalamin is recommended as first-line antidote due to its safety and efficacy, in association, of course, with oxygen and with further supportive treatment and adequate mechanical ventilation in the ICU. Thank you very much.
Реанимации, спасибо большое.
Thank you for your participation and interesting.
Спасибо огромное за ваше участие, интересный доклад.
And the next speaker would be Dr. Arne Christian Skolberg from
Christian Skolberg из Норвегии, и он будет говорить об опыте своей страны.
Thank you very much.
Спасибо огромное за приглашение. Для меня большое удовольствие посетить Узбекистан, Ташкент, быть на этой конференции. Я, безусловно, очень счастлив. Я работаю как анестезиолог и врач экстренной медицины. Я вот буду говорить также о налоксоне. Ну, необходимо признать конфликт интересов, что мой университет имеет контракт по поставке назальных спреев. Я не получу никаких выгод, но может получить мое начальство. Я буду говорить о различных при этом назальных спреях. Ну, начнем с базы фармакологии налоксона. Это опиоидный рецептор, антагонист опиоидного рецептора. Он именно нейтрализует опиоид, об этом нужно помнить, что он не удаляет опиоид, но затормаживает его. Когда используется налоксон, это когда необходимо обратить опиоидные эффекты, конечно, главная озабоченность здесь это респираторная депрессия и сниженное сознание. То есть это эффект аналгетика, который является побочным эффектом, и поэтому налоксон как побочный эффект вызывает респираторную депрессию. Ну, какая доза, с которой знакомы все, значит, при внутривенном, внутримышечном вливании это 0,4 до 0,8 миллиграммов до того, как начнется титрация. Ну и, конечно, этот опиоид может вызвать привыкание, зависимость. Ну, а кроме этого, довольно мало побочных эффектов, то есть довольно безопасный. Что касается назальных каналов, нос пригоден для применения различных лекарств. Когда есть хороший спрей, можно очень многие лекарства использовать, и не нужно специального оборудования, это может сделать сам пациент. Но для эффективности необходимо сделать специальные условия, то есть маленькие объемы, 0,2 мл, для того, чтобы покрыть вот эту часть носа для системного всасывания и для достижения высокой выживаемости. Думаю, что было очень много опытов с налоксоном и некоторыми другими лекарствами, когда они наносили на нос, но очень часто это лекарство проглатывалось, он попадал в фаринг, потом через пищевод в желудок, но это проблема, поскольку он влияет на это болезнь. Поэтому для избежания этого необходимо маленький объем, высокая концентрация. Теперь, значит, историческая справка, что когда ВОЗ рассмотрел этот вопрос и сказал, что налоксон будет эффективным, когда используется внутривенно, это была дополнительная квалификация, но при этом свидетельство об этом довольно низкое. Я из Норвегии, Ребекка, которая за мной будет, она из Лондона, было сделано очень много исследований, и о них я вам сегодня расскажу. Значит, первое исследование было, значит, скорая помощь, какие больные пациенты использовали налоксол, мы собрали данные, пропустили их через компьютер, проанализировали и получили результаты более 1000 случаев налоксона, и участвовало в исследовании 465 больных.
Многие делали инъекцию героина, и в течение года было очень много случаев передозировки героина. Это в основном были мужчины возрастом порядка 35 лет. И клиническая презентация была довольно интересной, потому что уровень комы Глазго составлял 3 из 15. И, конечно же, опиаты, они вызывают подавляют функцию дыхания, то ничего недостаточно для достаточного обогащения легких кислородом. То есть мы давали налоксон действительно больным, которым нужен был действительно антидот. И два из наших исследований с добровольцами мы наблюдали делали исследования по наблюдению фармакодинамики. Мы вводили налоксон внутривенно в разное время одному и тому же пациенту. Я хотел бы вам показать вот фармакодинамику, кривая на графике. То есть ось X это время, это с 0 минут до 2 минут, а пилометр это ось Y, вертикальная. И когда мы начали наше исследование, мы получили среднее количество порядка 7 миллиметров, и потом сжатие, то есть мы МИОС снизили, то есть пациент получал ремифентанил, это синтетический опиат, который используется в целях анестезии, то есть мы снизили, точнее индуцировали миозис, и после этого дали налоксон. И посмотрели, обращает ли налоксон миозис в обратную сторону. То есть синяя – это внутривенная, а красная кривая – это через носоглотку. То есть мы видим, что действие налоксона при введении внутривенно было гораздо более эффективным, потому что мы давали внутримышечно и в носоглотку 8 миллиграмм. И мы пришли к тому, что уровень, как я уже говорил, через носоглотку одними и те же дозами, то есть эффект был ниже. Вот это вот измерение динамики действия. И, конечно же, вот фармакокинетические измерения. Ось X – это время, ось Y – это концентрация налоксона. И мы можем видеть опять, синий дает гораздо более высокую максимальную концентрацию в сравнительно короткое время. И мы подумали, 0,8 миллиграмм это слишком мало, нужно давать больше. Поэтому потом мы произвели расчеты и следующие испытания. 1,4 налоксона вводились. Это вы видите, это фармакокинетические измерения, 30 минут, ось X, а Y – это концентрация сыворотки налоксона. Зеленая – это внутримышечная, а красная – это через носоглотку. Они смотрятся, отличаются, но с точки зрения статистики разница между ними двумя незначительная. И мы обнаружили, что с точки зрения фармакокинетики они близки друг к другу. То есть и мы начали уже проводить клинические исследования. Мы еще их не закончили, то есть сегодня я их не смог презентовать, но я думаю, я обязательно ими поделюсь, как только мы их закончим. Я также хотел бы подчеркнуть еще один момент. Вот большая линия точками, которая проведена, это очень высокая концентрация от введения внутривенно. То есть это используется для пациентов с зависимостью от опиатов. И из нашего опыта скорая помощь вводит именно внутримышечно, потому что если внутривенно, это требует времени. Введение в вену, особенно для тех, кто практикует инъекционные наркотики, вену, может быть, найти достаточно сложно. То есть, и это слишком быстро повышает концентрацию, то есть может стать триггером. Это вот вкратце я попытался вот описать, как может быть использовано, если специализированно сформулировать использование интранолоксона. Есть несколько продуктов на рынке США, то есть высокая концентрация, используется также спрей, и я думаю, что это средство может быть хорошей альтернативой как для людей-потребителей, так и для экстренной медицинской помощи. Я думаю, что проведенное исследование было очень интересным, и интерналоксон продвинет, то есть во многих местах мира. И в Украине мы использовали его для того, чтобы снизить уровень использования опиатных наркотиков. И спасибо университету, моему профессору Радалу, который научил меня всему, чему смог. Для меня честь быть здесь с вами, и я был бы рад ответить на вопросы, коль скоро таковые у вас имеются. Спасибо за вашу презентацию. У меня один вопрос. Вы сказали, что эффективность налоксона измерялась папиллометром. Если у пациента патология какое-либо из заболеваний, которая вызывает дегенерацию, то вы какие-то делали альтернативные измерения в вашем исследовании? Папиллометр, он использовался для испытания, не в клинической работе. Это были здоровые добровольцы. Потому что для случаев передозировки там мы скорее считали количество вдохов в минуту, потому что респирация для вентиляции легких и обогащения кислородом очень важна, и поддержание уровня сознания. Второй вопрос. Если пациент нестабилен, то есть гемодинамика, какое измерение является наиболее эффективным? То есть для использования налоксона в качестве антидота. Вы сказали высокая концентрация, малый объем, да? Если через носоглотку. Если гемодинамическая инстабильность, то есть если будет введен налоксон в носоглотку, то дальше циркуляции не будет, то есть будет заблокировки. Я думаю, для большинства пациентов с передозировкой опиатами у них либо будет нормальная кардиоваскулярная, либо у них будет сердечная недостаточность. Я тогда думаю, да, когда сердечная недостаточность, то есть налоксон нельзя будет использовать. То есть редко бывает с сердечной недостаточностью, то есть из моей практики. Я думаю, что носоглотка там тоже хорошо распространяется, если как бы циркуляция есть. Это не такая уж проблема. И третий вопрос. Мне очень интересно, в Норвегии уровень экономики выше, чем в Узбекистане, и по этой причине, может быть, у них достаточно денег на систему здравоохранения, но в наше время очень многие развитые европейские страны используют дексаметазин как замену опиосодержащим наркотикам, то есть их можно использовать вместо пропофола и фентанила дексаметазин. Какие-то работы исследовательские проводятся по этому. Я думаю, дексаметазон. Ситуация в Норвегии не сильно отличается от того, что на Украине раньше описывалось. И это, естественно, для общей анестезии, то есть довольно узкий круг. Я думаю, что чего Европа пытается избежать, чтобы не попасть в ситуацию с Соединенными Штатами, когда в комьюнити массовая выписка опиосодержащих средств практикуется. Я думаю, в больницах мы тоже пытаемся снизить рецептуру опиосодержащих. Но дексаметадон, кетамин и другие средства, которые как альтернатива используются. Четвертый вопрос: какая процедура хорошо известна в вашей стране, чтобы справиться с постоперационным делирием, потому что делирий, особенно для пожилых пациентов, это зависит от того, какого типа операция была. Я думаю, что мы можем с вами отдельно поговорить, потому что, обсудить уже тет-а-тет, потому что у нас тут тоже временные ограничения. Спасибо большое за интересный доклад, за интересное обсуждение, но я хотел бы задать один вопрос. Вы сказали, что есть показатели, общие показатели применения налоксона и контрпоказания, противопоказания. Основные показания – это снизить респирацию. Нет, для отравления метадоном или другими опиосодержащими средствами, но именно в анестезиологии, я думаю, показатели такие же для всех опиатов и для любого рода использования, легального, нелегального, то есть это на улице, либо после операции, то есть пациент, если плохо дышит, не может дышать, тогда ему дают налоксон. То есть как таковых противопоказаний нет, но необходимо быть аккуратными с дозировкой, потому что именно когда мы имеем дело с пациентами, у которых опиатная зависимость, потому что это очень опасно для пациента, и это как бить собаку, нужно быть очень аккуратным, и с налоксоном нужно мягко действовать, аккуратно, потому что если собаку бить сильно, она укусит. Это вот то же самое. Спасибо большое.
Но если позволите, перейду на русский и буквально небольшие тоже комментарии, поскольку мы в клинической токсикологии тоже достаточно часто используем налоксон в качестве антидота, но в результате ряда негативных последствий его использования мы все-таки подошли к определенным противопоказаниям для использования налоксона, в частности, при выраженной гипоксии мы все-таки
We're using naloxone. If hypoxia is expressed, we do not recommend naloxone because it could worsen the state and may result in complications of the state of patient. So we recommend emergency doctors to be like Arnie, like a doc. Which you should be careful is not to get bitten and not to face complications. And thank you so much. There is one more question. Комментировать по презентацию по руководству ВОЗ и руководство по управлению передозировками в комьюнити. Вы смогли бы объяснить концепцию применения налоксона, употребления в сообществе?
В Европе ВОЗ говорит о том, что люди, которые у кого может быть овerdose, нужно доступ к этому лекарству. Но это не только в этой стране, это во всем мире и в странах со средним и низким уровнем дохода. Вот Кыргызстан, Казахстан, Таджикистан, Афганистан, они уже внедрили это Это правило. Ну, и, может быть, вы объясните, о чем идет речь. Ну, я думаю, люди поняли, в чем был вопрос. Но концепция...
Even if you are not doctor, not nurse, not paramedic, you should have access to naloxone because overdoses happens everywhere. So that could be family, friends, people working in addiction services, or anyone else who are somewhere. And there's a strive through the UN and the WHO, I think, to expand the access to naloxone worldwide.
Thank you.
Спасибо большое.
Спасибо большое, уважаемые ратные.
Thank you very much indeed. We've seen, well, I think your presentation so far has stirred the most of interest and discussion. Thank you very much. Now, I would like to invite representative of Russian Journalist University, Pharmacological Correction of Non-Specific Injuries, with the patients with the dear colleagues, the importance of this presentation is explained by the high percentage of the patient with toxico-hypoxic encephalopathy in critical condition, and then the high lethality, and in this aspect we see certain peculiarities in the regions where do not have this centralized toxicology aid. The lethality can grow 10%, reach 10% as compared to other regions where such aid is present. Moreover, the fact that in the acute poisoning prevails of the neurotropic agents that affect brain, and based on the principles of the intensive therapy of acute poisoning, so they are in line with other emergency medicine principles, and it consists of the first aid, breathing, blood circulation, and activity of the brain, and it is also important to use methods to exit toxicosis reduction, or in other words, to remove toxic agent from the body. So intensive therapy at the toxico-hypoxy encephalopathy consists of two main processes. So the resupply of O2 to the tissues, and also administering combined anti-hypoxants right after the O2 supply was restored. Now, what are the mechanisms that helps to define the gravity of the patients in critical conditions with acute poisoning Well, there are two mechanisms. So the first is specific mechanism of the poisoning. So neurotropic agent poisoning and will lead to destruction of the life functions, first of all breathing and blood circulation, which also lead to early non-specific or universal damage mechanism, namely hypoxia, and as a result such patient is brought to us with both specific and non-specific mechanisms of damage. So on the slide, well, you could see as an example the patients in critical conditions at the early stages of methadone poisoning. In many countries, methadone is used as a drug for heroin, anti-heroin addiction for heroin, whereas the methadone, when it is administered intravenously, is up to between 24 to 72 hours and characterized by high level of addiction. So as you can see, when a patient is exposed to the poisoning for a long time, when the patient is in coma for long enough, we see lowered oxygen consumption, hypoxia of tissues of such patients will lead to the decrease of antioxidant protection mechanisms. The decrease of the antioxidant protection will lead to perioxidations of lipids, which were registered in high quantities, and since we don't have enough time, I will just say that I will show you the visualization of these changes of the MRI, and we registered the edema of the hypoxic genesis and the changes. The result what was seen thanks to MRI, so changes were quite specific and were different from classical acute brain blood circulation failure. So there's the basal nucleus and white matter of the brain, and a second difference is the retained functionality of ducts of the channels in the brain. So the very grave hypoxia of brains could it could be visualized, and with the edema and ischemic damage of brains, even if the vessels remain, there's no obstruction of vessels. In this case, we do not recommend, or rather advise against, antidote therapy, but rather recommend a general approach to restore O2 supply using artificial ventilation. Dealing with the respiratory and metabolic acidosis against the restoring of the O2 to tissues using medication which help to better absorption of O2 by the cells which are in the condition of hypoxia. So we use the metabolism correctors, centroflavin, and using this approach we were able to see on the third day better O2 absorption by the tissue cells which are in the condition of hypoxia, and we also see the recovery antioxidant processes and clinical changes characterized by the reduction of the coma time as well as the reduction of time under artificial ventilation, and also reducing the time in the intensive care unit. So the gravity of the patients with acute methadone poisoning is informed by both specific and non-specific mechanisms of impact. Non-specific mechanisms characterized by heavy hypoxia and further inhibition of the antioxidant protection and oxidation processes. So in these cases we recommend the approaches and treatments from the general ICU methodology, which would normalize oxygen supply to tissues and use of the measures to normalize the O2 by the cells in hypoxia. Thank you. Thank you very much indeed. If I may make a little comment as to what we have just heard, I would like to point out that the cases, or rather images that you saw, CT and then MRI, so they were made when the patients were admitted to the hospital. So all the changes that took place in the brain, they did happen, and it is worth noting that the patient with a heavy hypoxia and the use of Naloxone can bring to very bad conditions, because it is indeed a drug, and Naloxone is also, of course, have some protective effect on the central nervous system. It brings down the metabolism and the need for O2, and also neutralizes increasing metabolism and then O2 demand. So we may exacerbate the situation if we administer the drug. So ambulance service, many toxic substances may lead to apnoea. That's what we deal with as ambulance physicians. So have you administered as a reflectory non-central amylopatics? Do you have in your kit, your ambulance doctors, do they have these drugs? Do you mean the non-central impact analeptics, breathing analytics? No, in the kit, ambulance kit, we don't have analeptics. And as Alexei Nikolaevich said, in some cases, the patients already have very heavy hypoxic condition, and then using this breathing analeptics in this situation, which will increase the cellular demand for O2, will have a negative impact on clinics. Thank you. Thank you.
Okay, I repeat my question. The imaging studies, including CT and MRI, are not completely compatible with the
МТКТ не совпадает с простой гипоксией. Можно увидеть, что вот там есть части, которые очень сенситивны к кислороду. И в моем опыте среди молодого населения они Чербелум может быть задействован у молодых людей, и такое ощущение, что не только гипоксия может ответственность за осложнение метадоном, это непростая гипоксия. И вопрос тогда, если вы подчеркиваете антиоксиданты, используете вы какие-то специальные антиоксиданты или можете использовать любой антиоксидант? То есть можно использовать витамин И, например, витамин С. Делали ли вы какие-то испытания по этим оксидантам, чтобы есть ли какие-нибудь заключения по этим испытаниям?
Профессором Хусейном, что это действительно это нетипичная картина классической.
Typical classical hypoxia. When we have the classical hypoxia, then we also see the toxic edema of brain. Lactate acidose will lead to the damage of the redox system, and that the redox system will stop removing natrium. Natrium will drag the water, and then what we see is the expansion of the brain and reduction of the small part. So what we're trying to show, what we see with patients with the acute methadone, with the hyperhypoxia. So in winter time, they were found
somewhere with the 15-20% saturation. So nobody knows how long they remained in this condition. They might have remained 6-8 hours or maybe 24 hours in such a condition, and hypoxic damage. I agree with you that we were surprised when we saw changes that is similar to ischemic damage, and I agree with you. Whereas the vessels were quite intact, so it's not ischemic phenomenon, but what we saw on these images is very similar to the ischemic damage, and we believe it could be explained by this total hypoxia, which was suffered by the patients in the pre-hospital period. That's one. Now, regarding antioxidants, we use thioxinate, unlike vitamin E, which is also a very strong antioxidant, but it is fat dissolvent. That's why it doesn't have strong effect, and efficiency could be seen only on the third or the fifth or seventh day. So vitamin C also, it's a water dissolving antioxidant, but so when you administer it in large doses, it may inhibit the metabolic acidosis. So therefore, in this case, we used the succoic acid, which are water solvent, and since succinate is the fifth reaction of the hormone acids, so it triggers the whole breathing chain, and apart from the antioxidant mechanisms, it also had the antihypoxic mechanism. Thank you for your question, though. Thank you very much.
I have one more question to you. In case if research proves for anti-Remaxol, we cannot find anything on the basis of Cochrane or Medline. Instead, having such patients use plasmapheresis or ECMO. What's your opinion? Will it be better for recovery process? As medical therapy on the basis of citalopram, we do it as well, but it provides less effect. Thank you for the question. Yeah, there is no multi-central research for researches like for citalopram, Remaxol. Nevertheless, we report our data, which were obtained directly by us, and regarding methods of proof medicine, all of us, we don't understand that there are positive and negative features, and it's extremely difficult to make this test. There should be a huge massive of data and so on and so on, and the drugs of this class are comparatively new. They're just 15-20 years old. This is the first feature, and the second feature is that there are problems existing. We all know that farm business is business, first of all, and some groups of drugs and some data will not be published, and some researches are very difficult to find. And about plasmapheresis, for example, in case of plasmapheresis could cause hyperproteinemia, and recovery of metabolism will not be the only positive feature of plasmapheresis, but there is a decrease of endogen intoxication or intoxication, and it will not impact hypoxia at all. And CMO, you are being anesthesiologist, resuscitation specialist, you should understand. We have acute intoxication, methadone about 1,500 a year, about 1,000 go through resuscitation. Maybe CMO is effective, I fully agree with you, but first of all it's expensive and it requires specific prescriptions, and the method itself is very expensive. Okay, thank you. Thank you so much, Vasilievich. Very interesting discussion. The second report after Arno, but we have a dilemma. Since we're running out of time, Amayak Vazgenovich, who is the next, as far as I understand, he's radio online. Maybe we'll listen to his speech, and since the rest are here, we will go to have a break and reduce our break down to 5-10 minutes. So next speech by representative of Russian of Moscow Clinical School of Clinical Toxicologists Badalyan, Amayak Vazgenovich, Doctor of Medical Sciences, complex treatment of vipers, bite in patient research institute named under Sklifosovsky. I can hear you. Alexei Nikolaevich, good afternoon. Dear colleagues, the subject of complex treatment of viper bites at inpatient facilities. On every continent, more than 2,000 snakes and about 350 species is poisonous. 14 types on the territory of Russia. In Uzbekistan, 38 types and 5 of them are poisonous. It's eastern steppe viper, Central Asia cobra, Efa. In line with WHO data, there are 5.5 million bites every year, and about 2.5 people have intoxication on the territory of Russia. Most frequently, snake bites are typical for 3 types of snakes. Types of poisons are gamma-vasotoxic, it's like viper poison, and neurotoxic, it's aspic and sea snakes. Vipers poison contains ghialuronidase, phospholipase, and ferments, and impact is similar, and the impact of the poison, thin walls of vessels are destroyed, necrosis, tissue necrosis starts, and here you can see on the slide fangs of snake intoxication grade can be evaluated in line with the scale of damage. First, you can see only local reaction and bite traces, and the second is moderate intoxication, local inflammation, and the heaviest intoxication, big inflammation as a reaction of a body to histamine, prostaglandins, and serotonin. And after that, a patient gets vessel blockade. Viper's bite causes local changes and results in development of local disorder, which results in prolongation of treatment period and inflammation changes. Such changes and further complications require long-term drug medical treatment. The average time of conservative treatment is from 14 to 20 days, especially with local inflammatory tissue disorder. Within the first minutes after bite, there is itching, reducing, there could be venous thrombosis. Inflammation expands, skin color becomes crimson, and together with swelling of tissue, there are accompanying symptoms like heavy breathing, high temperature, collapse, loss of consciousness connected to intravessel coagulation, blood coagulation. And the point of our research is to raise the efficiency of viper bites by means of medical and non-medical. You can see on the slide, this is heavy intoxication, so system disorder. So you may see on the slide main group, comparison group, clinical indications in inpatient department as duration and frequency of symptoms is pretty typical. In toxicological department, general clinical and laboratory researches, we check all the patient, general blood test, biochemical blood test, urine test. In detailed check-ups, homeostasis parameters were evaluated. As initial data demonstrated, before pre-rehabilitation treatment, hematology disorders and hematological indicators, moderate leukocytosis, considerable increase of endotoxicose and leukocyte index of intoxication were noticed. Indicated disorders require correction, and in line with that, we provided basic treatment, conservative treatment to patients. It included the following: immobilization of limbs, anti-shock therapy, infusion of anti-poison serum, deletion of poison, correction of acid blood content, vitamin therapy, heparinization, antibiotics therapy, and basic therapy as non-medical treatment, ultraviolet radiation. Sorry. With inflammatory disorders, in order to remove them, we used magnetic therapy This is a low frequent equipment, Polus 3M, and ultraviolet radiation for external radiation, 11M piece of equipment. Main group also for the main group also used which therapy which started from the third day vessels of limbs in order to exclude vessel thrombosis. And biomechanical therapy started later with the help of equipment Biom Volna. We got one therapy a day. On the background of complex rehabilitation therapy expressed positive clinical and laboratory dynamics were observed on the background of general intoxication indications and normalizing body temperature and restoring wounded limbs function. So the swelling considerably reduced, and the patient was able to use limp-baited. On the background of complex treatment, we also noticed full correction of hemorrhagical disorders, and frequency and efficiency of correction increased 1.5 times in comparison with general group, and endogen intoxication indicators were reduced, and fraction of molecular peptides and intoxication index, you can see it in the green color. And considerable improvement was adaptation abilities of body. You can see it on the slide, and it's more than 27%. It's higher than the stress zone. From the clinical point of view, the main group statistically important reduce of symptoms, and in comparison group there is minor indications and duration of symptoms. You can see it in blue color. Considerable reductions, average treatment term, and group for patients with medical treatment, and for the group for wave biotherapy. Hence, in cases of viper bites, and in order to optimize medical process using non-medical methods like therapy, ultraviolet radiation enables to considerably reduce time terms of medical treatment with further elimination of endogen intoxication. And let me introduce video material of wave method in cases of viper bites in the conditions of inpatient facility. Thank you for your attention. I'm ready to answer your questions. Amaya Kvazganovich, thank you so much for your splendid speech. Amaya Kvazganovich, as a representative of Moscow School, presented his report and his new vision of treatment of toxicological profile patients, including non-medical drugs method and early rehabilitation methodics aimed at recovery, speedy recovery of functional disorders in cases of snake bites. If there are any questions, I do believe it's a relevant problem for Uzbekistan as well. No any questions. Thank you so much, Mayak Vazganovich. Thank you. Now we're having some circumstances. We're having only 3 speeches, dear colleagues. So that's why I propose to continue working without a break and finish early and have some time for further discussion. And for the next speech, I invite esteemed Professor Hossein from Iran, who agreed to come to our conference. He has 2 speeches, first about body packers and syringes, diagnostics and emergency treatment, an overview of last 3 toxicological outbreaks, and availability of main antidotes in line with WHO data. Дамы
Uzbekistan will face some of these patients, let's say body packers. I'm not sure if you have seen these patients. They are hiding the illicit drugs inside the body, and
когда они пересекают границу различными видами транспорта, и обнаружить вот таких вот перевозчиков живых очень сложно, если не случился передоз. И во многих аэропортах есть отдельные инструменты, которые могут быть использованы в таких случаях для того, чтобы начать полицейское расследование. Или если, скажем, получена информация о том, что такой вот такая живая посылка пересекает границу с наркотиками внутри организма. Я хотел бы рассказать вам об опыте вот как вы видите вот на этом слайде,
between body packers
видите
and body
разницу
stuffers.
между
In body
способами перевозки
they
наркотиков. Те, значит, которые прячут наркотики внутри своего тела, скажем, внутри желудка, внутри желудочно-кишечного тракта, если женщина внутри вагины, и таким образом они пересекают границу для того, чтобы потом продать этот продукт на другой стороне границы. И многие из этих пациентов вот, в нашем институте, мы знаем, что вот владелец, перевозчик может, собственно, очень много выручить денег за одно пересечение. И таким образом они являются вот такими перевозчиками, и им представляют проживание в гостинице, ну и какие-то деньги им дают на руки за перевозку. А вот то, что называется другой вид перевозки, это люди, которые, собственно, не планируют перевести наркотик, но когда им приходится спонтанно проглотить наркотик, чтобы избежать досмотра или обнаружения при досмотре. Ну и, конечно, таким риском интоксикации, потому что в первом случае мулы, они более подготовленные, а во втором случае происходит спонтанное заглатывание наркотиков, и, собственно, в первом случае можно найти внутри такого перевозчика большое количество наркотиков, ну, скажем, начиная от 100 граммов до 2 килограммов
But in body stuffers, usually the amount of
если
illicit drugs are...
речь идет о вот второй группе людей, то количество таких глотателей, наркотиков в теле глотателей относительно небольшое. Ну вот мы посмотрели статьи, которые существуют на английском языке с концентрацией на клинических манифестациях, клинических
sort of studies we can do to understand who is body packer and who is body stuffer. This is a simple X-ray of a patient, and if you have noticed in the right side, you can see similar oval-shaped materials that somehow is very similar to fecal impact. Unless there are some actually differential manifestations that we usually relied on that. You cannot expect to see fecal impactions, for example, inside the stomach. But and if you see something like this, you should be suspicious about body packer patients. And if you can see, unfortunately, I have no pointer here to show you. Isn't there any pointer? Yeah, you can see here, and also you can see here the packs. And if you see closely, you can see a hollow of air around of each pack. So it is a specific manifestation of a body packer. Because air is trapped between the illicit drug and the sheath around the packer. So you can see, for example, this one. It is completely evident that around the pack, it's a layer of air, and also in a close observation, you can see at the end of the packs, when the people knock the pack, you can see something similar like a rose. So we call it rosette sign because of the trapping of the air at the end. And here, you may imagine that it is a normal X-ray. But if you look in deep, you can see that here it is a pack. And actually it was an accidental finding in an ordinary patient that came to us. And here it shows that possibly in some cases contrast studies can help you. You can hear, for example, the contrast around the pack. But if we compare body packers together, in our experience, non-contrast studies are more useful than contrast studies. Why? I can show you why. This is one of our studies that was published in clinical toxicology, and it is going to compare contrast studies versus non-contrast studies in body packers and body stuffers. And if you see in the body stuffers, you can see radio opaque, so when you use contrast studies in that situation, you cannot see the packs. I will show you in the slides. Yeah. The bad news is that the chronometer is working and I'm not talking. Yeah, as you can see, when we were using contrast CTs in body stuffers, the rate of successful detection of the packs was less than non-contrast CT. And overall, you can detect body packers much better than body stuffers, and it is completely evident because of the size of the packs. And if you see here, for example, when we haven't used the contrast, we could detect here the body stuffers. But here, when we use contrast, we couldn't detect them because it's covered the packs. It's covered the baggies. And also, in terms of the number of baggies, we were more successful using non-contrast CT in detecting the body stuffers. Yeah, and another actually procedures that it is easy in emergency departments is using long windows, because you cannot usually detect some of the body stuffers using abdominal view, and I can show you how it can affect your practice. You can see in this slide, in the left side, probably you can be suspicious that it should be a pack. But when you use at the same level. When you use long window, you can easily detect the PACs. So it would be another procedure that you can see the PACs in suspicious patients. And here, again, in the left side, the radiologists couldn't detect anything, but when we use the long window, we could detect the baggies here and here in two parts. And here also you can see the trap of the air inside the baggies. And here also, sometimes it is opposite. When you use abdominal view, you can detect the baggies, but when you use long window, you cannot detect it. So the best procedure is using both of the procedures to detect more baggies inside the body. And it is interesting that, for example, this is actually body smuggler, and the baggie was containing the contents of different drugs altogether, and sometimes it makes a strange imaging studies when you see the patients. And here, actually, we use low contrast CT scan for following up the patients, because when at the first try you detect some PACs inside the body, it is not necessary to use the previous imaging study in order to follow the patients, because actually in this way you are imposing a lot of X-ray on the patients, so it would be useful to use low voltage CTs in these patients. And here it shows that low CT images, low contrast CT images is not useful for detecting the leakages of the PACs. You can see here the leakages of the PACs as a radio opaque material inside the intestine, but you cannot detect at the same level with low contrast CT scan. And again here, sometimes people that think that surgery always work to remove the PACs in some poison patients. By these slides, I am going to warn you, it doesn't work always, and sometimes it facilitates the poisoning process. Because the surgeons usually use milking technique in order to remove the PACs, and in this technique, actually, you are stimulating the PACs in order to be leaked. And unfortunately, these patients died after surgery, because you can see in the left side, there were two baggies inside the body, and after surgery, the size of the bags are reduced. Why? Because the material released and the patients died. So our general recommendation is not to consult surgeons for body stuffers, but for body packers, the story is different. And you can see here again, it's another case, and unfortunately this case also died after surgery, and you can see PACs here before surgery, and no PAC, and just the remaining of the PAC after surgery, and the patient died because of the toxicity. As a result, there are lots of diagnostic pitfalls among body staffers and body packers. And in our experience, and also this experience is approved by the other studies, abdominopelvic CT scan without contrast would be the best procedure to diagnose these patients. And but we should use these techniques with caution with the previous history, And also we should be suspicious about the body packing, especially if they are coming from terminals, if they are coming from train stations, those places that these patients are communicating from city by city or from airplane by airplane. Okay, thank you very much for your attention, and I'm happy if you have any question to respond. I lost the time, sorry, because because the electricity was gone.
Thank you very much. And next report.
Yeah. In this presentation, I'm going to show you our experience in toxicological outbreaks and the availability of WHO guideline, WHO antidotes guideline to overcome these toxicological outbreaks. So briefly, what's the difference between epidemic and outbreak? As you can see here, epidemic refers to increase, often sudden, in the number of cases of poisoning above what is normally expected in that population in that area. So something that is usual for you may be considered as epidemic in another country. So all of those refers to what you have expected from a poisoning. Outbreaks carries the same definition of epidemic, but is often used for more limited geographic area. So the objective of this study was to review 3 major human toxicological outbreaks and to elaborate the possible role of essential antidotes in minimizing the burden of these toxic exposures. This is the list of antidotes that was released from WHO in 2019, and you can see here there are some non-specific general antidotes, including activated charcoal, and also specific antidotes, including N-acetylcysteine, atropine, calcium gluconate, methylene blue, and also naloxone, and as we have already talked about that, penicillamine for metals, Persian blue, sodium nitrate for cyanide poisoning, and also after that one they had released a complementary list, and on top of that the fomepizole that is used for toxic alcohols, and also desferoxamine used for iron poisoning, dimercaplor used for metal poisoning, and finally sodium calcium edetot that can be used also for metal poisoning. We could see that almost during 4 years, more than 1,000 patients died during recent outbreaks in Iran, and I'm going to show you how was the outbreaks and how we could act against that outbreaks in Iran. And unfortunately, most of the patients who died were young people who were affected by these outbreaks, except that then mortality of patients, we had lots of blind patients because of the methanol poisoning, unfortunately. And if you consider the average age of life in each country, and considering that these patients are usually young people, many of the public health resources should be used for these patients in order to have a near normal life for these patients, but somehow it is not possible. First, I'm going to talk about the mushroom poisoning in our country. I can show you that from April to June 2018, more than 1,200 patients referred to different emergency departments in different areas of Iran, including northwest, west, and central parts of Iran, due to mushroom poisoning. Lepiota was the main mushroom that was involved in Iran in that area. And unfortunately, at the beginning of the outbreak, nobody could detect that these mushrooms are poisoning, and even local experts couldn't distinguish in that time between poisoning mushrooms and actually what is edible by ordinary people as a natural mushroom. And unfortunately, some of the patients released from emergency department because the emergency physicians thought that these mushrooms have no severe manifestations, so they released the patients. And among those released patients, some of them died later because they could experience hepatic damage, and finally died because of hepatic encephalopathy. So we have an idiom in clinical toxicology and also in other parts of the medicine that time is tissue. So in order to serve as a good practice for these patients, you should consider time and manage appropriately on time on all of the patients that refer to us in emergency department, unless like this bad scenario, we may lose some of our patients without any antidote, using any antidote. This was the actually the advertisement that was released by Iranian Ministry of Health on that time, and fortunately, after this warning sign, the rate of mushroom poisoning reduced very well. It is written that don't consume self-growing mushrooms, and also make sure you are buying healthy mushroom when you're buying mushroom from bazaar. Buy boxes packed and other warning signs that's labeled by Ministry of Health. Do not consume high amounts of mushroom, especially when it is raw. And also the good warning sign was that poisoning mushrooms is very similar to edible mushrooms, and also ingestion of mushrooms by animals does not necessarily mean that the mushroom is safe. So it was another good warning sign for the community. And after these warning signs, fortunately, the number of cases decreased dramatically. So even for us as a clinical toxicologist, we cannot determine between edible mushrooms and poisonous mushrooms. So it would be another outbreak in Iran was methanol outbreak. We have unfortunately 3 big outbreaks in Iran. And in the last outbreaks, we lost more than 1,000 patients during just 4 months. And these outbreaks that I am going to present you is an outbreak before COVID-19. And as you can see in 2018, and just we had 900, nearly 1,000 patients in different area. And unfortunately, many of them died. And I should say that because of the COVID and lack of alcohol and other sanitizers that people usually use, it was a lot of alcohol in hand of the ordinary people. And they thought that because these alcohols can be used for washing hands, it can be also used for killing the virus, COVID virus. So many of the patients tried to disinfect themselves by drinking alcohol. So we could see at the same time the signs of COVID-19 presentation and methanol poisoning. And we have published it, and you can search it and see that these patients had both disease at the same time. But unfortunately, still the source of alcohol is available, and we haven't back to our normal visits of methanol poison patients, and still the number of the methanol poison cases are high in our country. And unfortunately, many of them are not dying many of them are get blind. And imagine that a patient like 8 years old is dying, and the community should continue support of these patients for 78, at the average age of 78 or 80 in for example, in Iran. The most problematic issue in methanol poison cases was lack of knowledge by our emergency physicians. Unfortunately, many of our doctors are not familiar with methanol poison cases, and just they treat the patients like the ethanol poison cases. But these two scenarios are completely different. When someone gets ethanol, they refer very early, let's say within 2 or at most 6 years later, 6 hours later. But in case of methanol poisoning, they come very, very late, usually more than 24 hours. And if someone is coming more than 24 hours with a history of ingestion of alcohol and with vision loss or vision impairment, it could be a methanol poisoning, and just you can check it by a blood gas, by a simple blood gas that is available almost everywhere in the main hospitals. So it would be a good idea if you check them. And for me, for example, when I find someone with a methanol poisoning, I am thinking about the similar source of methanol poisoning in the community, and ask the patients to bring the other people, unless you have to wait into the hospital and see the patients in a very, very bad condition. And sometimes you have not enough bed for dialysis the patient, and you may lose some of your patients. And you can see here the brain CT scan of the patients with involvement of frontal lobe and also occipital lobe in different days, and also brain edema in some of the patients. And this is a kit that we could use during the outbreak for our patients to detect if they use methanol. This is a calorimetric test that could differentiate between ethanol and methanol. By the way, the last outbreak in my country was lead toxicity, and many of the addicted patients, opioid addicted patients, came to the emergency departments with severe abdominal pain, that none of them were responded to opioids, and some of them went under surgical operations, but the surgeon couldn't find anything, and finally we found that they are lead toxicity. What was the source? The source was contaminated opium. And as you can see, the lead is radio opaque, and this is a piece of opium here, and you can see after X-ray you can detect several metal-shaped radio opacity inside the opium. It is lead, and the concern was that, especially for Western countries, if we are importing opium or other opioids from Afghanistan and neighboring countries to the West, so the heroin also could be contaminated with the lead. So it was another concern, and you can see here, for the first time, actually radiologists couldn't interpret these X-rays as a normal X-ray. But if you see clearly from close, I'm not sure if you can see here, especially in this picture, very tiny metal-shaped materials that it is lead. And when the fecal content is compressed, you can see it clearly. And interestingly, many of the patients were treated just by passing the fecal materials, because the constipation is also an added value for stimulating the pain for these patients. And you can see the lead encephalopathy in these patients. You can see the different parts of the brain is involved. These are all from our patients. And interestingly, this picture, that is combination of two pathology, body packers and lead inside the packs. I try to point to the lead inside the packs. Yeah, and these are the packs that retrieved from the patients. So, as a conclusion, the burden of toxicological outbreaks may be underestimated. Antidotes may play a substantial role in minimizing the effect of toxic exposure. Difficulties in the availability, technical, economical, regulatory, and geographical aspects are essential barriers to antidote availability, particularly in developing countries. Thank you very much for your attention. If you have any question, I am happy to answer.
Thank you very much for your interesting report. Но поскольку у нас ограничено время,
since we are limited in time, I do believe we'll postpone the discussion for later. And now Rebecca MacDonald with the report from Great Britain. Naloxone availability worldwide, results of monitoring and implementation of the program of damage reduction period from 2016 to 2020. Please, the floor is yours.
First of all, in the meantime, let me thank the Uzbek Ministry of Health and the organizing committee for inviting me to be here, and in particular Amir, who I believe has been here since 6 in the morning, and also all of you who are still here for the very last session of the conference, and it's greatly appreciated. Finally, let me thank also the IT team, who, without knowing it, sometimes need to stage emergency interventions. And finally, my slides are here. So I'm here to, in a personal capacity, and I'm here to not present on my work, but to have a conversation with you. And my conversation will be based on data from the organization Harm Reduction International, and will also involve the work that colleagues of mine have undertaken together with me. Right, so, okay. These are my declarations. I have worked together with industry, and I have worked for the United Nations. In fact, it was in August 2019 that I got to attend a training for the UN regional program for Afghanistan and neighboring countries, such as Uzbekistan. And this is where I met Puno Megaban, who presented earlier today, and also Hussein Hasanyan. And I would like to thank you and also Arna for previously presenting on naloxone today, which makes my job a lot easier now. All right, so you might wonder why I'm here. I'm not an emergency physician. In fact, I'm a psychologist by training. And you guys get to do the work. I just talk. I talk that's what I do all day long. And so I'm here to talk to you about why, as I learned yesterday in emergency medicine, time is of essence, and why that particularly matters when we talk about opioids, and how we can prevent people from dying from opioid overdose and from having long-term morbidity related to opioid overdose. And by opioid overdose, I mean anything from heroin to long-acting opioids, any opioid agonist that you can think of. So again, this is just briefly a picture from the training in Iran, in Tehran, on the diagnosis, treatment of opioid overdose, and withdrawal at Lokman Hakim Hospital. And this was very much based on the 2014 WHO guidelines that Arna previously presented, that in their key recommendation that I and colleagues together developed, stated that people likely to witness opioid overdose in the community should have access to naloxone the opioid antagonist, the essential antidote we just heard, so that lay people, not emergency physicians, but opioid users themselves, their family members and friends can intervene and administer the antidote to the person who is unconscious, who's not breathing, in the interest of basically reducing the time for that person to receive the antidote. So we really don't want to wait until the person presents to the emergency department before they can get naloxone. This is just to bridge the time between the event of the overdose and their arrival at the ambulance, or the arrival of the ambulance, and their potential admission to the emergency department. And in fact, 2 years later, a, to me, key paper was published, which was based on the cascade of the heroin metabolite. And by looking at post-mortem reports, Professor Shane Dark of Australia and his toxicologist colleague determined that the majority of people who suffer heroin overdose in the community are alive for at least 25 to 30 minutes following injecting of heroin. So this means yesterday I learned that there's the, we call it, I think, the golden hour that we can, that you guys can intervene in emergency departments. When we're talking about heroin overdose, we really don't have a full hour. We have 25 to 30 minutes. And I learned yesterday that here in Uzbekistan, the target time for the arrival of the ambulances is 15 minutes-ish. Well, if we deduct those 15 minutes from the 25 to 30 minutes, we don't have a whole lot of time left. So time is of essence, and that's why the World Health Organization believes that it's important that anywhere where there are opioid agonists in the community, there should also be naloxone as the key opioid antagonist in the community. And naloxone should be made available to anybody likely to witness an overdose. And those people should be trained to administer naloxone. So, let's have a look at the map. This is a slide that was put forward again by the United Nations. My interest, my background is not drug policy, but I believe you will recognize the map and you will recognize that you're one of the many countries that border Afghanistan, and Afghanistan is considered one of the main producers of opioids, of heroin specifically. And your region, Central Asia, is one located along the trade routes of heroin into the Russian Federation, and Iran is located along the trade route, for instance, of heroin towards Western Europe. So what we did to understand where we can find naloxone in the community, we just looked at the databases of the Organization Harm Reduction International that I mentioned previously, and we really wanted to get a better understanding of to what extent naloxone is available in countries that have to deal with heroin overdose in the community. And we specifically wanted to look at low-middle income countries such as the region of Central Asia. So we looked at their reports and were able to determine that here in Eurasia, 9 out of the 29 countries already have take-home naloxone available. So community-based naloxone is available here in the region, and many countries have chosen to implement it together with the United Nations in many instances. So just before I continue, are there any questions about community-based naloxone or why we might want to implement community-based naloxone and give it to lay people? Is the principle clear so far? Have you heard of it? Yeah? Okay, great. I'll continue then. Okay, so here's just, to illustrate the point, here's the example of a take-home naloxone kit that the United Nations, together on a joint project with the World Health Organization, have implemented in Kazakhstan, Kyrgyzstan, and Tajikistan. And you will see the kit in the bottom right. So the kit consists of 2 ampules of 0.4 per mil concentration. And this is given together with 2 muscle syringes, with an alcohol pad, latex gloves, a sharps container, and a leaflet with instructions to people in the community who are likely to witness overdose. And in fact, this kit is as cheap as $1 each. So $1 can save somebody from suffering fatal overdose. And you'll see in the map that, as I indicated previously, Kazakhstan has taken naloxone, Kyrgyzstan has implemented take-home naloxone, Tajikistan has implemented take-home naloxone, and in fact our colleagues in Afghanistan had also implemented take-home naloxone in 8 regions of Afghanistan, and this was the status up until August of this year. I don't know what the status is right now because our colleagues are not working on this project anymore. But just to illustrate that this is very much in the interest of the region of Central Asia, because you are located along the trade route of heroin coming from Afghanistan. Okay, so you will know these press images. On the right, you will see President Biden, who in August 2021 this year, of course, announced the withdrawal of the U.S. troops from Afghanistan. And President Biden is the U.S. Commander-in-Chief, and it's his responsibility to protect U.S. lives, and he withdrew U.S. troops with 0 U.S. soldiers missing in action. So he fulfilled his role. However, you will also remember the image on the left. In fact, I, as a national of Germany, should thank you, especially the citizens of Tashkent, for allowing your airbase, your airport, to be used for the emergency evacuation flights of many people from Afghanistan to save their lives. So I think we can all agree that the situation for our colleagues in Afghanistan is uncertain. It's a big question mark. We don't know what's going to happen in your neighboring country. And I can only show this slide again, showing the trade routes. And my understanding from our tour of the hospital with Amir 2 days ago was that Uzbekistan currently does not see any narcotics in emergency medicine. And of course, if that's the case, that is a achievement of drug control. If despite the joint border with Afghanistan, Uzbekistan does not see any opioid poisonings in emergency departments, that is a great achievement. But we don't know what the future may bring. And I say this because in Afghanistan there is no more U.S. money, U.S. interest, to help with information and protecting the Uzbek border. So it's possible, I don't know, but it is possible that Uzbekistan may see an influx of heroin in the future. We just don't know. So all I can say is, from my perspective, representing also the WHO guidelines, is that in emergency medicine, I think you would want to be prepared for potential emergencies. And therefore, we might want to think together about whether or not Uzbekistan might want to follow the lead of your neighboring countries, Kazakhstan, Kyrgyzstan, and Tajikistan, to think whether you can make naloxone, the essential antidote, available in the community, so that if heroin were to enter Uzbekistan, you would have the opportunity to save people's lives in the community. And I was very pleased, in fact, to see many of the colleagues who presented yesterday from the neighboring countries were people that I've met when I was on mission for United Nations in your neighboring countries. And I hope they would be able to assist you if Uzbekistan wanted to make this implementation possible in terms of policies and necessary steps that you might want to take. So that's it for me, and spasiba, and Rahmat for having me, and I'm now going to hand over back to the chairs.
Thank you very much for your interesting report. I would like ask any question, but we have limited time. И поэтому я хочу, так сказать, сказать, что
therefore, unfortunately, we have no time, but we exhausted our agenda. We've listened to very interesting presentations. We had some outstanding discussions. I think we'll continue it at the margins of our Congress, and now I'd like to invite the organizers to proceed to the closing ceremony.
Good evening, dear participants of 5th Congress of Emergency of Uzbekistan, first Eurasian Congress of Emergency Medicine. It's an honor for me to present today's ceremony of closing of the Congress. Today we have in Presidium Chairman of Association of Emergency of Uzbekistan, Professor Hadjibayev Abdulhakim Mominovich, academic rector of St. Petersburg Medical University named after academic Pavlov, chairman of Russian Association Sergei Fyodorovich Babnenko, General Director of Republican Scientific Emergency Institute Laganov, Davron Bakhtiarovich. Dear friends, as far as you know, it has become a good tradition in the course of our Congress. We make decoration with honored professor of emergency center. It was introduced in 2017, and specialists are decorated who considerably contributed into development, and since introduction 9 persons was decorated: Sergei Fedorovich Babnenko, Babnulin, Parfenov, Alexeyev, and Mr. Zamatin. From Germany, Gunnar Strote, chairman of GZ. From Turkey, Bashar Jander. And from Azerbaijan, Kurbahan Muslinov. Dear colleagues, in 2021, based on the decision of Management of Association and Emergency Center for outstanding contribution in development of emergency of our country, honored professor is granted to Dr. Anders Jansen, the chairman, Institute of Robert Koch, Berlin, and the director of Institute of Cooperation. And nomination is given to the chairman of association by Hadjibayev Hakim Ominovich, professor. And for the next receiving of the next nomination from the name of Genelids Institute, Professor Vadyagin, please. And based on the decision of the Management of Association of Emergency and Emergency Center for considerable outstanding contribution, the medal and diploma are given to Mr. Manukovsky Vadim Anatolievich, Doctor of Medical Sciences, Professor and Director of Institute of Emergency named after John Elidze. And for outstanding contribution into the development of emergency of Uzbekistan, diploma is given to Afonchikov Vyacheslav Sergeyevich, manager of nosology and resuscitation of Department of Institute named after John Ridze. Thank you so much. Dear colleagues, let me move forward. So today we have a competition of young scientists, and upon the result, based on the result of the competition, let me name the winner. So the prize, third place, as well as money in amount of 1 million sum, is given to Polatova Shekhnoza Haidarovna. She was here with us online. It will be given to her. She's in Bukhara Emergency Center, Bukhara Department. Second place and 2 million sum to Mustafa Fakhror Lukmanovich, doctor from Samarkand branch of emergency, and certificate is given by Chairman Professor Hajibayev, Professor of Emergency Association. And in line with the decision of our commission, first place and the price and amount of 3 million sum is given to Dr. Pulatov Mahmud Muradovich, Emergency Center, and academic Babnenko will give the prize. Sergey Fedorovich, thank you so much. Dear colleagues, we prepared the resolution of 5th First Congress of Eurasian Community of Emergency. Today's participants. And in order to conclude, the floor is given to Babnenko academic. First of all, I would like to thank all the participants and the organizers, Abdulhakim Muminovich, and all the board of association and management of emergency center. Everybody who made efforts in order to have such a splendid Congress yesterday and today, in the first Congress, International Congress of Eurasian Association of Emergency Specialists. You know, we discussed it between our organizers and shareholders, and it's God's will and provides an opportunity to ask Abdulhakim Muminovich to become a head of this association for upcoming 5 years. And saying frankly, we completely understood that even a few days we couldn't dream of it, having understanding of workload of Abdulhakim Muminovich. He is the most experienced specialist among us, and we just yesterday we discussed that with Mr. Basharov, what to do. We need powerful, good association, because there should be annual congress and somebody should do it, and in this regard we really hope for experience and energy and charisma of our leader, Abdulhakim Muminovich, and with all possible efforts we're going to help it. And 9 and 10 June 2021 in St. Petersburg, 2022, during white nights, and we're waiting for everybody, and we will have a huge amount of work with Abdulhakim Muminovich. And this is the resolution of the Congress to agree with the proposal of the organizers to ask Professor Hajibayev to become a head of association for upcoming 5 years, to approve proposal of Petersburg section to have next Congress in St. Petersburg, and it's further, it's understood that a special decision of association and resolution of Congress about organizing of emergency in Uzbekistan since 5th anniversary Congress was related to it as well, and it's about key features to introduce triage system, single system in every inpatient emergency department's 5-level triage system is a golden standard, to develop a protocol routing scheme on patients for transporting and hospitalization to newly organized centers. That's what is to say. So that's the working in direction of modern centers, like modern receiving centers is a solution when diagnostic and treatment base is becoming expensive. There should be a workload, so that's why we need to form centers, because there is not a huge percentage locally, so we need to make it concentrated, and it solves the problem of efficient use of heavy diagnostic equipment, surgery blocks, support for centralized sterilization, minimal invasive technologies, and searching specialists for these centers, because it's very difficult to find a specialist for a load center than to an idle center. And that's the one of the key decisions which will be approved by the resolution of the Congress, and we really think that decision makers will support it and continue working in this direction. Okay, it's understood. Preparing, training specialists of these sections. Of course, these are modern sections with all the technologies, and I would like to say the training specialists for these sections, it's a totally different training level than emergency team doctor. It's totally different specialist who represents integral specializations, enabled to provide diagnostic services and medical treatment, and transfers only some specific patients to the more specific specialists. We already worked that, and did a huge cognitive problem for specialists who are supposed to agree that urologists will not be called for kidney, or surgeon will not be called to appendix suspicions before 6 hours observations. If there is a need of laparoscopy, if laparoscopy is not needed, patient goes home without a specialist. Hypertonia without cardiologist, brain commotion, and specialists is supposed to make decisions and to provide medical treatment to solve this problem, and the specialists are supposed to be trained, and that's why, saying frankly, and one of the most important about structure of calls to restructure emergency service and to increase part of teams, and the doctor should be part of these emergency vehicle teams, because it's related to decision making, doctors' university knowledge. But I think we replaced definition transportation. We called it medical evacuation. It's more military, but in fact it's totally different, because medical evacuation then in process of transportation medical treatment is provided and medical specialist availability is required. So if it's related, it's different cost, it's different level of opportunities, and it's different quality and availability of medical services. That's why any movement of vehicles, B, C, on the availability presence of a medical services, it's medical evacuation, and it's understood for everybody that it includes medical service, even if it's only surveillance, and that's why it is proposed to increase share of medical teams. It's forming single dispatching centers. Informatization, it's a next further step to make medical help more available. A medical evacuation should be as prescribed after first medical contact. It's understood that this is not a region or interregional level. If it's specialized, an evacuation is required for third level, subject level, but if it's super complicated situation and there is a need to evacuate to Republican level, that's supposed to be done. And I'm really glad that we're following the same way. I don't understand that there are many obstacles on this way, but this way is correct, it's right. And the last point, as far as I understand, no, it's number 8, to develop and introduce mechanism of sustainable additional financing of the center and its branches. Now here, yeah, I support every letter. Yeah, let's applaud and take into account fast increase of Uzbekistan's population, to increase bed spaces front of the center by organizing resuscitation bed space red zones, which are required from the first minute to start diagnostic process on the background with lethal functions. Actually, every point is are the part of the system and define efficiency of all the systems functioning. So I made the commission. Now should we vote or we just accept? And if there are any changes or additional features, we'll just approve it as head of association. Thank you so much, Sergey Fedorovich. And in order to finalize the protocol, I need to say that during 2 hours we listen for more than 160 reports from more than 20%, more than 2,000 participants were online, and for ceremonial now Chairman of Association of Emergency Association, Hadjibayev Abdulhakim Imonovich, the floor is yours. Good evening, dear participants of the Congress, dear friends, esteemed guests, participants of 5th Congress of Emergency Association, First Congress of Eurasian Association of Emergency Physicians. So due to the existing circumstances, in the beginning of the Congress I didn't have a possibility to take part, but I was receiving information of any process. It's not less important. The finalizing process is the same important as the beginning. So we finalized, and I'm glad that I'm taking part in the final part of the Congress. And as far as I'm informed, and due to the fact that we have here at least 100 participants, I do believe that first Congress was successful, and I congratulate you. And of course, I do believe it's difficult to overestimate the importance of this event for 2 days, but all important can be seen from afar. I do believe the days will go by and we'll think and understand the importance of this event, because all of us are well aware that pandemic of coronavirus outbreak lasts almost 2 years, and it separated us from each other. But we are doctors, and especially doctors working in emergency system. In every country they were on the front line, and they were the main who were responsible for saving lives of tens of thousands. And we had losses. I'm more than sure in all the countries our anesthesiologists, resuscitation specialists, laboratory specialists, and life has demonstrated once again how important this section of medicine is important. Yes, there is economical development, new medical technologies are being developed, but the direction of providing emergency medical services is of more and more relevance. And pandemic forced us and trained us to communicate and to train in online mode. And very many of such events inside the country, among a few countries, are organized in online mode. But I do believe you would agree that no any online mode will replace face-to-face interaction. Yeah, online mode you can transfer information, but apart from information sharing, there is something which can work only in the course of face-to-face interaction. And I do believe this part is extremely important, because as it was already mentioned, these two events, there were participants of more than 22 countries who participated, many of you online mode reports, which are without any hesitation are of high interest, and we are succeeded in doing that. And from my name and from the name of organization committee, I would like to thank our esteemed guests. Any event starting from the wedding ceremony and ending up with Congress is valuable because of guests. And let's say thanks to our guests, and thank you so much. And I'm sure that every participant, every guest will come back home not only with having additional information, but with the peace of our friendliness, and that will make us closer. And I would like to also thank our distinguished sponsors, since any kind of event is organized with financial support of sponsors, and we have a series of pharmaceutical companies, medical companies. I'm really grateful, and thanks to speakers, to participants and Congress organizers. We really appreciate it. Yeah, and I do understand that it's not just a symbolic position which I was nominated for, which academic Babnenko proclaimed, because 5 country founders of our community, Uzbekistan, Russia, Turkey, Kazakhstan and India, and if I will be the chairman in the course of upcoming 5 years, so I see my task is first of all to be in touch, to have feedback and sharing information. Second, publications. Meanwhile, we don't have a single magazine. I do believe that we'll organize such a magazine within these 5 years. We have emergency magazine, emergency medicine. There is emergency service magazine by Institute of Sklifosovsky. There is a magazine in Turkey and in India, in Kazakhstan. But yeah, and I do believe that during upcoming few years, if we have enough publications, we will have to organize publication, actually magazine by Association of Emergency, and of course on an annual basis we'll organize meetings.
And of course with support with the co-founders and my personal friend, academician Naga, and the Bashanjarai and other chairperson from the co-founding countries, I'm sure we'll be able to accomplish it. Once again, I would like to congratulate all of you, and also to pass the symbolic banner to the hosting city and organizer of the second Eurasian Association Congress. Well, with this we're concluding the first Congress. Thank you very much, and we'll see you soon.